قريت ما عملت له بريبريشن يعني لانه
لأنه
اقدمه.
محمد he is not with us right now. He
أيوة
has
بس
a technical issue.
ايوه بس I need few minutes عشان اقرا اجهز حاجه عن تقديمه. ما جهزت حاجه لانه كان المفروض يقدمه دكتور محمد.
أنت عندك السي في؟
عندي السي في بس ما عندي بايو، يعني اقدر اشوف.
The floor is yours. Go ahead.
Okay.
Muhammad, go ahead.
Okay. Hello, everyone. Good evening. Good morning for people across the Atlantic. Buonasera, Prof. Andrea Biondi. And thanks to everybody who is joining us today. Thanks to the society, the Saudi Society of Blood Disorders, which is hosting the annual Saudi Hematology Congress on a yearly basis. Welcome to the audience, welcome to speakers, and of course, thanks for all the supporters, the organizers, and the sponsors. Today is a special day because it's a pediatric day. It's day 5 of the conference. The aim of this conference is to share knowledge and updates in hematology from really national and international experts and figures in the field. The agenda today will cover 2 themes. The first part will be focusing on leukemia, and the second part will be on hematology. It is a great pleasure to share this first session myself. This is Muhammad Isa, pediatric hematologist and a stem cell transplanter from King Abdullah Specialist Children's Hospital, National Guard Riyadh, and I'm sharing and co-moderating this session with Dr. Muhammad Sayed, who's a consultant pediatric hematologist, oncologist in King Faisal Specialist Hospital in Medina Al Munawwara. And it's given me great pleasure to introduce Prof. Andrea Biondi, very well-known figure in the field, and he is a professor and director of pediatric department, as well as the head of the pediatric residency program at University of Milano. He's also, of course, the head of chairing the International BFM study group. Also, he's a scientific director of Titamanti Research Center. He has been leading in the past the SIOP Europe and as well as the AOP group. His focus, of course, on research and molecular characterization of ALL in children, and everybody knows him, published many articles that we refer to. So the Prof will be happy to hear you talking about pH positive ALL.
Well, good afternoon and good morning. First of all, many thanks to you for the very nice words of introduction. And thanks again for the Saudi Society for Blood Disorders for the invitation. Although it's a real pity that it's not face-to-face, but it's still virtual. But I hope that in the future to have the chance to visit your country and as well your centers. So the aim of my presentation is just to share some of the topics related to a relatively rare disease in children and adolescents, which is the pH positive ALL. And I will try to organize my presentation by just dealing with the lessons from the clinical trials. What are we doing? What are they still the open question? And the two major questions are, of course, what is the best chemotherapy backbone? What is the best TKI to be used in children and adolescents, even based on the adult experience? Finally, can we replace chemotherapy backbone? And it's going to be the next future, even for the pediatric world. Finally, the role of transplantation, and if we'll have time to discuss briefly, an entity which is something, I would say, probably unique to the pediatric field, which is the so-called CML-like pH positive ALL. First of all, as I already said, pH positive ALL is relatively rare subset. We are dealing with between 2 to 5% in different, according to age, from 0 to 18. Of course, if you include into the pH positive ALL the newly defined Abelson class fusion, definitely we are dealing with probably double the incidence of this disease, but still we are dealing with a rare subset which before the TKI area has been associated with a very dismal prognosis in the pediatric setting. And even now, with respect to the very important results with the TKI in chemotherapy, is still the prognosis is still inferior to all other genetic subsets mostly occurring in pediatric ALL. This is just to give you the landscape where we came from before the TKI area, and thanks for the incredible cooperation which I believe is sharing around the world, that when you have a rare subset, you need to cooperate if you want to get as fast as possible answer to your question. This is just the results of the largest retrospective study which has been organized through this network, which is called Ponte di Legno. Ponte di Legno is a mountain venue in Italy, very nice, which basically hosts the first meeting of this international network, which is still keeping the name of the first meeting more than 25 years ago. And as you can appreciate, before the time of the TKI, even according to the different age, you see that the prognosis of this disease was still very dismal. And more important to your attention, that as you can appreciate, most of the children underwent at that time, before the TKI area bone marrow transplantation, after the initial course of induction and consolidation. But this has completely changed the landscape, and TKI changed the landscape even in the pediatric setting. Of course, we are dealing with a rare and accordingly a limited number of studies, and in this very nice review by Steve Unger group, you have probably the most important study which brought to the registration of firstly of the imatinib and later on of dasatinib, even for the use of pediatric pH positive ALL. This is the first study which has been done a long time ago by our colleague of the Children Oncology Group, that clearly demonstrate that the cohort 5, which basically was a cohort of patients who did receive, not continuously, but to the largest extent, the TKI exposure, was basically the cohort of patients who did achieve the best prognosis as well compared to the bone marrow transplantation, opening the path to the use of the TKI plus chemotherapy as a substitution of stem cell transplantation in newly diagnosed children and adolescents with Ph-positive LL. And this is the results of the European consortium, which is within the IBFM and is called ESFOL, European Study Ph-positive LL, that took the challenge, differently from our American colleagues, to address the question in a randomized manner, to give a TKI at the end of induction, and to see whether the impact of the TKI can really change the landscape of this type of disease. And it has been done, as you can see the results on intention to treat analysis, which clearly show that the imatinib, even in a context of large use of stem cell transplantation as a consolidation step, we are talking about the early 2000s, and at that time it was a paradigm in Europe as well in US and Canada to use stem transplantation as a consolidation tool for patients with Ph-positive LL. This has been confirmed even with a long follow-up, but again, in these two preliminary studies, which basically brought to the registration of imatinib for Ph-positive LL, the imatinib at that time was given after the end of induction. And of course, this was completely changed when, based on the findings in the adult setting, we realized basically that as early you give the TKI, as better you can achieve the quality of the remission, even in terms of molecular remission. And this, of course, was the results of the subsequent study, which clearly demonstrate, as you can appreciate by this cartoon, the comparison of the quality of the MRD remission, molecular remission, whether it was when the TKI was given at the end of the induction A or at the end of the induction B, highlighting the concept, which was very well known in the adult setting, that as early you provide the TKI, better is the quality of the remission, and accordingly the strategy to be used. But of course, imatinib was the first TKI which has been used in the pediatric setting, but of course, additional study later on addressed the question, is it dasatinib providing a better control of the disease and accordingly a better outcome with what has been achieved by using imatinib? This question was addressed by 3 independent studies. This was the original study from the COG by using a very intensive backbone of chemotherapy. And as you can see, in both the standard risk and the high risk Ph-positive LL, the event-free survival, which basically measure the quality of your treatment, and of course you can compare strategy with another, was very similar in that study with with those provided by larger study in the use of imatinib. But then just in the 2020, a Chinese study, which has been conducted very well done and managed by our colleagues from the China's Children Cancer Group, the CCG-ALL 2015, addressed the question in a randomized manner whether by using the same type of chemotherapy backbone the use of different TKI can make the difference. And they demonstrated that in their hands, the dasatinib provide a better outcome, especially for the control of CNS disease as well, relapse. Two major points about the study are the following. First of all, they did use a higher dose of dasatinib per square meter per day that was different from what has been now registered for the use in the pediatric and adult setting. And the other thing that was rather surprising, that the results of the imatinib was significantly inferior as the one reported by the Children Oncology Group and the ESFAL Consortium in Europe. More recently, and this is the study that was a pharma-driven study which provided the regulatory agency in the US, the FDA, and in Europe, the EMA, to approve the use of dasatinib in combination with chemotherapy for the treatment of pediatric Ph-positive ALL, clearly didn't show a significant benefit in terms of survival, again, EFS survival at 3 years as compared to the previous study, suggesting that apparently in this study, it doesn't seem to be a benefit to use dasatinib instead the original one, TKI, which has been extensively studied in the pediatric and adult Ph-positive ALL. So just to summarize, what we did learn so far are basically summarized in this slide. 2 different backbones, the intensive chemotherapy of the either the COG and the ESFAL based on the IBFM high-risk blocks of chemotherapy, 2 TKI, imatinib and dasatinib, an overall event-free survival approximately of 70%. The majority of patients can be treated without SCT. There was no clear advantage on the use of the high-intensive chemotherapy backbone of the COG versus the ESFAL, and no clear advantage of imatinib versus dasatinib. So we still have the question, what is the best chemotherapy backbone that can we use for getting the best results with the lowest profile of toxicity in the pediatric setting? And this is the question which is currently in place and addressed by an investigator-driven study that I'm very pleased to chair in jointly with Louis Silverman from the Dana-Farber Cancer Institute at Harvard in Boston, where basically we address the question, can we compare the 2 different type of chemotherapy, the standard arm, which is basically the ESFAL, intensive high chemotherapy blocks of chemotherapy, versus the investigational arm, which is basically the COG high-risk ALL 232 backbone. And the study is ongoing. And just to give an update of the current status, because it's a transatlantic study between Europe and North American COG study, the study is running very well, although it was, can you imagine, a global investigator-driven study and with a very rare subset in many centers around Europe and, of course, on the COG sites in US, Canada, and other countries around the world. The first surprise that we didn't expect to be, according to the plan of the study, that most of the patients are basically standard risk, and standard risk are defined according to the lack of MRD detection after the first 2 cycles, the consolidation 1A, 1B, and the different blocks of chemotherapy for consolidation, suggesting that the intensity of chemotherapy plus the use of TKI can provide a very good control of the disease. Of course, the study is a non-inferiority study because the aim is to try to reduce as much as we can the toxicity profile that we learn is significantly higher in this subset of disease when we combine chemotherapy and TKI. This is already well known in the previous study. I'm just reporting the previous ASPHAL European 2010, where basically at least 80%, so a significant proportion of the patient experienced CAE, and most of the CAE was infection. And of course, one of the critical issues from the clinical care is how to handle toxicity. And these are basically some suggestions that we jointly with our colleagues from the COG are very pleased to share. The reason being that as experience in the adult setting, but I have to say that from the pediatric perspective, we are not used to have so significantly high of toxic death for a chemotherapy, even intensive in the high risk, suggesting that the combination of chemotherapy plus TKI can really explain, because if you compare the same percentage of toxic death in the high-risk non-pH positive LL as compared to the pH positive LL with the same chemotherapy backbone but plus TKI, the percentage of toxic death is significantly higher in the second group. What TKI? We are just discussing this issue. Apparently in the pediatric setting, it doesn't seem, with the exception of the results of the Chinese study, to be a significant difference between imatinib and dasatinib, which are currently the two TKI which has been approved by the regulatory authorities and accordingly can be used as a standard of therapy in combination with chemotherapy. But of course, the key question, and this is even more important for the pediatric world and landscape, because if you ask the question to a pediatrician, I'm sure that the answer would be, we want to treat and to cure more, but with less toxicity. And that, of course, is one of the challenges that we are facing today. And in that context, of course, the aim to substitute the intensity of chemotherapy with the immunotherapy approach can be, as already shown to occur in the adult setting, a very important perspective. And of course, the question is what type of immunotherapy dealing with the monoclonal antibody and CAR-T as well. And this is, of course, you have summarized in this cartoon what are basically from the perspective of the pediatric landscape, the advantage of the blinatumomab versus inotuzumab to be considered instead of chemotherapy backbone. What are we doing? And this is a very novel and still unpublished because it's still working process. And I would like to thank our colleagues, Tai Hoa from the COG in Canada, who is currently leading the task force between European and North American countries to address the question, what is going to be the new generation of protocol for the treatment of pH positive LL in children and adolescents? And of course, the question is, can we substitute the intensity of chemotherapy by using jointly with the TKI the blina course? And of course, this is going to be addressed in a randomized manner. As you know, as a pediatrician, we are used to apply randomized study as the best way to proceed in our knowledge, although it might be challenging considering the rarity of this disease. The other important information I want to share is that, again, in the same line of our adult colleagues, we are already considering in the ongoing study. The one that I mentioned before is addressing what is the best chemotherapy backbone jointly between SFOL and COG. We have already decided as amendment to include the Abelson class fusion BLL, because we do believe, as all evidence suggesting, even with respect to the retrospective analysis of the outcome, even in the pediatric setting, that Abelson class fusion positive BLL biologically and clinically phenocopy pH positive LL. And accordingly, even in the ongoing, but definitely in the future, we are planning to include, and as you can see, between the 3 to 5%, we will add a 2-3%, which will be a significant, still relatively rare proportion of pediatric LL. One of the key messages I want to share with you that probably was one of the most important achievements of the current strategy, that only a minority, as you can see in the current study, less than 14% of children and adolescents, considering the molecular poor response to the treatment, are eligible in first line to receive transplantation. And considering that the most recent data on the randomized conditioning regimen question brought to our attention that despite of our hope, TBI is still the best of conditioning regimen for for pediatric LL, as Christina Peters recently reported of the international study on the randomized question of TBI versus non-TBI regimens. This is an important challenge because we are fully aware of what are the medium and late long-term effects of TBI-based transplantation regimen. Can we use TKI after stem cell transplantation? As probably you know, even in the adult setting, the results are rather controversial because we do have a study that clearly showed that in the adult setting, patient transplanted in CR1, there was a more favorable disease-free survival on multivariate analysis, and it was associated with a lower common incidence of acute GVHD. By contrast, the CIBMTR, the consortium of bone marrow transplantation for North American centers, didn't show any benefit on the use of TKI for adult CML, so not pH positive LL, but CML setting. So it's still controversial. And the current study in the pediatric setting is studying the feasibility of using in the post-transplant setting, the TKI in the high-risk pH positive LL, who are the only one eligible in first CR. And again, I remember, a very low percentage, 14%, as compared to between 60 and 85% in the pre-TKI area. Of course, one of the questions is how I treat and how to treat relapse pH positive LL. And these, of course, are basically some clinical suggestions that, of course, highlight a few concepts. First of all, many patients who relapse pH positive LL have been successfully salvaged through reinduction and consolidation followed by SCT. And this, of course, explains the difference between an EFS of 65 to 70% and an overall survival of 80%, because a percentage of patients who relapse can be salvaged by reinduction. And of course, if you consider that today the reinduction can avoid the use of chemotherapy, thanks to the study which clearly showing the adult in pediatric setting that the 1 or 2 cycles of blina before, independent of chemotherapy, or after a first cycle of chemotherapy can be the best way to achieve a remission before transplantation, provided an even more significant hope to further increase the results of this group. One thing I want to mention, different from adult, because we are in adult pediatric setting, is that the CAR T can be, of course, considered as well. And more important, the last point is that children with PH-LL do not develop, or it's a very, very rare events of point mutation, even at the time of the relapse. Finally, let me discuss something which is unique and possibly, I hope, a matter of discussion. A very nice and extensive study from our colleague from Czech Republic, Jan Zuna and the CLIC group, reported a discrepancy between the MRD detection as assessed by the use of IG and TCR clonotypic marker, and as compared to the BCR-ABL genomic breakpoints analysis. Suggestion that by using this BCR-ABL genomic breakpoints, clearly identifying something different, persistence of the molecular disease. And this is clearly a very nice picture of his work. And actually, this been already, and the work is still ongoing, but soon to be published. They provided a European analysis with all the pediatric patient LL, starting by the discrepancy between the mRNA detection of the BCR-ABL and the IgTCR, and then in those cases performing a genomic breakpoint cloning in order to achieve a PCR DNA-based comparable of the Abelson fusion, BCR-ABL fusion gene as compared to the IgA and TCR. And what one possible explanation, and this is probably, I argue, something different from an adult setting, because if you ask the question, do you have cases of Ph-positive LL that a diagnosis can be considered blastic crisis of a CML? It occurs, but it's very rare event. And in most of the case, Ph-positive LL diagnosis are indistinguishable by all the de novo acute lymphoblastic leukemia. And so one possible explanation is to consider that the typical versus CML-like leukemia could potentially rely on the different type of target clone, which are basically interested by the events, as you can see in this cartoon, which clearly reflect what we can define the typical ALL. In this case, of course, a clone of lymphoid precursor can be probably the target of the genetic transformation. By contrast, in the typical CML-like, where basically you have the transformation with the BCR-ABL occur in a multi-progenitor, but then later on, the expression of the disease and the need of having secondary events, which can be the Ikaros deletion gene, can basically be responsible of the pattern of clinical expression. So in both cases, you have a clinical expression such as lymphoid leukemia, but what is behind in terms of target cell transformation and according to the multi-step disease can be substantially differently. And these are basically my conclusion that I would like to share with all of you, thanking again for the opportunity. There is no doubt that even in the pediatric setting, targeted therapy has completely changed the landscape of treatment for Ph-positive LL. And the most important achievement is that only a minority of children with Ph-positive LL should be considered eligible for SCT, even because TBI regimen is still the option based on the recent randomized international study chaired by Christina Peters. Still open the need of use of TKI after SCT. New TKI can cover the need of targeting mutants, which I want to underline that is still relatively rare in the pediatric setting. But finally, let me share that the future, and this is basically what we are planning to consider and to work with for the next future, is to replace the extensive need of chemotherapy blocks with immunotherapy, either monoclonal antibody and CAR-T, which we believe might further improve the cure while reducing long-term side effect. And so with these words, I would like to thank all the team. We are the largest center in Italy for the treatment of hematological and hem-onc diseases, including transplantation and gene therapy by using CAR-T. And of course, we are welcome, and I'm personally welcome to answer the question that have been presented. Thanks again for the invitation. With my best.
Thank you very much, Prof. Biondi, for your excellent and really inciting for the future treatment of PH positive ALL patients. Actually, in the sessions, we'll leave the questions until the QA question session at the end. We could right now, if you're okay, possibly to move to the next talk that will be presented by Prof. Wassel Jastania about the management of MRD positive ALL. Everybody knows Prof. Wassel Jastania at the national level as the chairman of oncology at the King Faisal Specialist Hospital Research Center in Jeddah, and he has very long contribution to the field in Saudi Arabia, especially in leukemia transplant and sickle cell. So we'll move to that talk accordingly.
Good afternoon, everybody. First, I'd like to thank the organizers and the scientific committee for this wonderful meeting and for inviting me to participate in this important meeting. And in this particular session that focuses on pediatric leukemia, together with eminent speakers in the session, which both are making my talk both challenging and easy. Challenging in being among these eminent speakers, and easy because the topics that they are covering actually support a lot of what I am about to say. So the title that I've been asked to present is the management of MRD positive pediatric ALL. And I'd like to go over the content. I'll go over a quick introduction, and then MRD-based risk-directed approaches, quick overview of the most recent published NCCN guidelines for pediatric MRD-positive ALL, and then a suggestion on how should we approach and manage MRD positivity in this setting. And I'd like to really have a disclosure here that this talk will focus on the management of MRD positivity in the frontline therapy for Philadelphia negative pre-B acute lymphoblastic leukemia. And this is an important disclaimer to make, as what I'll attempt and show in the next 20 to 25 minutes is that when it comes to MRD, one size does not fit all, particularly in the era of precision medicine. And hopefully I can deliver this key take-home key message by the end of this talk. So despite the 80 to 90% of patients with ALL achieve a hematological complete remission after induction therapy, still a substantial number of patients continue to exhibit minimal residual or measurable residual disease positivity, which I will refer to as MRD in this presentation. In fact, up to 50% of adults with ALL will have MRD positivity at end of induction, and up to 20% of pediatric ALL in CR will have MRD positivity at end of induction. And from multiple studies up to date, we know now that MRD strongly predicts overall survival and event-free survival in both pediatrics, as shown in the top figures, and adults, as shown in the bottom figures. MRD is the strongest predictor of relapse in both the pediatric and adult ALL setting. Despite this knowledge, the question that I'll try to address is that, is there evidence to support that MRD-based risk-directed treatment improves outcomes? In particular, is there evidence that reducing therapy for MRD-negative patients improves outcome? And in contrast, is there evidence that escalation or change of therapy for MRD positivity improves outcomes? And I'll try and answer both of these questions in the next slide. So starting with the first question, does reducing therapy for MRD negative patients improve outcomes? And quickly, a study that was recently completed and published, which is the Children's Oncology Group 0932 study, which had in its eligibility the NCI standard risk acute lymphoblastic leukemia patient population. And NCI standard risk are those that are 1 to 10 years of age and have a white count of less than 50 at the time of diagnosis. This study recruited patients from 2010 to 2016. And among its objectives is addressing the therapy for standard risk low patient populations. And standard risk low was defined as ALL patients, NCI standard risk patients that had favorable cytogenetics defined as the presence of ETV6RUNX1 or the double trisomy positivity of chromosomes 4 and 10, had CNS1 status, and had MRD levels at day 8 peripheral blood and day 29 bone marrow less than 0.01% as measured by flow cytometry. And 2 different low-risk regimens were tested in this population, the standard COG 0331 regimen and the P9904 regimen. The 0331 regimen was labeled as the LRC regimen, and the P9904 was labeled as the LRM regimen. And the LRM regimen was a regimen that had no anthracyclines, no alkylating agents, and had 6 doses of intermediate or dose methotrexate of 1 gram per meter square without leucovorin rescue. And the study was published recently in 2020 and showed outstanding disease-free survival results with a 5-year DFS of approximately 99% using either regimen, and a 5-year overall survival of 100% using either regimen. However, despite both regimens being well tolerated, given that anthracycline alkylators and Capezi methotrexate with asparaginase was used in the LRC regimen, the rates of mucositis and allergic reactions were higher in that particular regimen, which is the LRC regimen. And this study confirmed that the application of stringent risk criteria that includes MRD at different time points in a favorable risk group results in an almost certain cure with either low-risk regimen, allowing optimal selection for this particular patient population. The question, however, is that can we do better? Does MRD method really make a difference? Is detecting lower levels of minimal residual disease an important aspect that will allow us to even select patients more precisely? We know that flow cytometry, which was used in the majority of North American studies and clinical trials, was the main method and detects up to 1 to 10 to the -4 blasts in the marrow. PCR is used mainly in the European trials. However, recently we now have the high throughput sequencing or the next generation sequencing, which can detect levels up to 10 to the -6. And this was a question of a number of recent studies that looked at different methods of MRD detection between NGS and flow cytometry. In this particular study, this study looked at the population of the 0232, which is the NCI high-risk population, and the COG 0331, which is the NCI standard risk population, and compared the flow cytometry MRD measurements with the high throughput sequencing or the next generation sequencing using the clonoSEQ approved method. And compared these results in paired samples. And what was found is that there was a high discordant rate between the NGS method and the flow cytometry, with the NGS method detecting approximately 39% more patients that are MRD positive at the time points that were tested. In addition, patients that had NGS negative MRD were significantly better in terms of overall survival in both the standard risk and the high risk cohorts. However, those that had MRD negativity by flow, but MRD positivity by NGS had an intermediate risk survival that was significantly lower than those that were negative by a more sensitive technique in detecting MRD. A pilot study looking at the standard risk population, looking at the population that was completely negative by NGS, by the NGS MRD technique, showed that the 20% of patients that had no detectable residual clonal sequencing by NGS at end of induction had a EFS of 98% and an overall survival of 100%, compared to those that had any level of NGS detection at end of induction. And this included patients with and without favorable genetics. So again, indicating that using a more sensitive method in detecting MRD negativities are at even higher levels does impact outcomes in this particular population. However, I did mention initially that I will not talk about Philadelphia positive or other genotypes, but this is just to raise a point, and I'm sure this is mentioned also by Dr. Andrea in the original talk. But this study looked at different methods of MRD detection in the Philadelphia positive ALL, using the flow cytometry technique, the immunoglobulin T cell rearrangement PCR technique, or the BCR ABL1 PCR technique. And in this study that was published in abstract format a number of years back, it showed that despite there's a good concordance between studies, the best concordance rate was between the immunoglobulin T cell rearrangement PCR and the flow cytometry, with 90% of samples being concordant. However, BCR-ABL1 PCR was not as reliable as flow as a backup test due to technical issues and variability in results. In particular, that results tended to be more positive. And when it came to transplant recommendations, HSCT recommendations could be made in 98% of patients when MRD was measured by flow, 84% when immunoglobulin T cell rearrangement was used, but only in 39% when BCR-ABL1 was used as the method of MRD testing. And this study concluded that for patients not enrolled on clinical trials, using flow for MRD assessment is perhaps the most practical method in North American centers. And however, NGS was not formally tested in the Philadelphia ALL population studies in these particular studies. Similarly, the SFAL, the European, have also compared MRD detection in the Philadelphia ALL positive population and compared the immunoglobulin T cell rearrangement PCR method with the BCR-ABL1 method. And as shown here, there were higher positivities when the BCR-ABL1 method was used compared to the immunoglobulin T cell rearranged methods. And although the concordance rate was pretty good at approximately 70%, the study tended to have a significantly higher positivity by the BCR-ABL1 method. And this study concluded that when it comes to MRD assessment and measurement in this particular study, the immunoglobulin T cell rearrangement appeared to be more reliable as a method of MRD detection. So despite that, the BCR-ABL may be more sensitive or specific when it comes to different genotypes, different methods may be more reliable than others, and the other methods may need further validation and testing. So we've talked about MRD dose reduction or regimen reduction in therapy for patients that are MRD negative, but how about escalation or change of therapy for those that continue to be MRD positive? And a number of studies that have tried to address this particular question, and one of them is the UCAL 2003 study that randomized patients that had MRD positivity between standard therapy using regimen B versus regimen C that included the BFM augmented backbone in addition to 8 doses of PEG asparaginase, 18 doses of vincristine, and escalated dose IV methotrexate without folinic acid rescue as additional to the standard regimen B in this particular study. And this study has shown that with chemotherapy intensification for persistent MRD at end of induction, defined as an MRD above or equal to 0.01%, the intensification favored augmentation with a trend of improved outcomes. However, they did mention that augmentation of treatment was associated with more adverse events than standard post-remission therapy. And this notion of increased toxicity when intensifying chemotherapy for MRD positivity or for high-risk features has also been shown in other studies. So for example, this is the Children's Oncology Group 1131 study that intensified the high-risk backbone by incorporating clofarabine and other chemotherapy intensification methods to patients that had very high-risk features, including those that had day 29 MRD positivity of 0.01% or more. This study was closed early, and that was due to the unacceptable toxicity that was associated with the very high-risk regimen that incorporated more chemotherapy. Similarly, from the 0232 study that included NCI high-risk patients, patients that had MRD positivity or slow early response, received a double delayed intensification and interim maintenance. And although this showed that early on, the curves for those that received double delayed intensification and interim maintenance were high, at the 3-year level, the survival curves for both event-free survival and overall survival crossed, suggesting and indicating that further intensification of chemotherapy for NCI high-risk patients with positive MRD at end of induction delays but does not prevent relapse. So how about MRD levels at end of consolidation? Can we stratify patients further? Do all patients that are end of induction MRD positive need a change in management? And this study was published back in 2015 by Borowitz et al. That looked at end of consolidation MRD stratification for patients that were end of induction MRD positive. And based on a cutoff of 0.01%, patients that were MRD negative at end of consolidation had an event-free survival at 5 years of approximately 79%, which was very reasonable, despite MRD positivity at end of induction. However, those that had MRD positivity at end of consolidation had a very poor 5-year event-free survival of 39%. So how about NCI standard risk patients? Do these patients with end of induction, end of consolidation positivity by MRD do as poorly as NCI high-risk patients? And this was a study that was published recently that looked at end of consolidation positivity in the NCI standard risk group, and again stratified by end of consolidation MRD positivity. Although there was a significant difference in the 4-year disease-free survival between patients that were end of consolidation MRD positive versus negative, the overall survival, the event-free survival, disease-free survival is approximately 73% for those that were end of consolidation MRD positive versus 90.7% for those that were end of consolidation MRD negative. However, despite this significant difference in disease-free survival, the 4-year overall survival was above 90% for both disease population, and it was not significantly different. So these patients were easily salvageable despite the significant difference in events. So to summarize the end of induction, end of consolidation MRD positivity by NCI risk, NCI standard risk patients that are end of induction MRD positive have a 4-year disease-free survival of 90% when they're end of consolidation MRD negative, and 73% when they are end of consolidation MRD positive. However, their overall survival rates exceed 90%. In contrast, those that are NCI high risk, end of induction MRD positive, and end of consolidation negative, they have a reasonable disease-free survival of approximately 79%, and at an end of consolidation MRD positive, if they're end of consolidation MRD positive, a disease-free survival of 39%. So based on these results, there is really no clear evidence to justify intensifying therapy for the NCI standard risk with end of consolidation MRD positivity beyond the high-risk backbone therapy, given the acceptable and reasonable outcome and the overall survival seen in this particular population. until the results of the 1731 are available. And this is the current ongoing COG trials that are really testing whether incorporating immunotherapy for this part, NCI standard risk, high risk, and those with end of consolidation positivity is beneficial. And I'm sure that this will be covered by Dr. Gupta in the following presentation. So we talked about NCI risk, but how about genotype? Does genotype impact MRD stratification and management? And this is a very interesting study that I enjoyed reading, which was published a number of years back, that looked at genotype-specific MRD disease incorporation to see if that can improve risk stratification of pediatric ALL. And allow me to take a minute in presenting this data. So this figure is from the UCAL 2003 study that included more than 2,500 patients. And it looked at the proportion of patients, as shown here in the density, that are positive or negative at different levels in different areas, as shown in the height of the curve. And also the risk of relapse, as shown in the scale here, that those that had low risk of relapse of approximately 1% in light yellow versus those that have high risk of relapse in dark burgundy, as shown here. And when the full population collectively, you see that despite the majority are MRD negative at this particular threshold, the risk of relapse starts really increasing gradually, somewhere between 0.01 and 0.1%, but becomes more evident as we get closer to 5% at end of induction. When subgroups are by genetic subtypes are looked at differently, you find that both the height of and proportion of patients at different levels change, but also the color density changes despite the increasing MRD levels in these particular populations. So for ETV6-RUNX1, you don't see the burgundy color here. For high hyperdiploidy, you start seeing the darkness in color as we approach 5%. For the intermediate risk, the colors start changing as we increase 0.01%. And for the high risk population, you see that the color starts getting darker even before the 0.01% level. And when you look at, when they looked at the T-cell ALL phenotype, there was quite a variability with no dark burgundy seen even at levels, except when you reach levels above 5% or even when you reach levels of 5% or more. So based on this data, they were able to create an integrated risk group of standard risk, intermediate risk, and high risk, incorporating different cytogenetic subgroups as defined below here, and different MRD thresholds with each group that represent different percentages of patients with different risks of relapse and different risks of high risk relapse, showing that only 8% of the population here have a significantly low EFS, higher risk of relapse, lower overall survival, and most of these relapses or a big proportion of these relapses were high risk relapses in this population. So based on this, they said that they concluded that although the risk of relapse was directly proportional to the MRD level within each genetic risk group, the absolute risk of relapse that was associated with a specific MRD level varied by genetic subtype and immunophenotype. And just a word about MRD in T-cell ALL. This is the study from the Italian BFM group 2000 that showed that when you look at time point 1, the risk of relapse, if you're positive at time point 1, was not significantly different at different levels as long as you were negative at time point 2. However, if you were positive at time point 2, the level of MRD the risk of relapse increases as the level of MRD increases. This study concluded that MRD at time point 2 constitutes the most important predictive factor for relapse in childhood T-cell ALL. So based on this and on a recent consensus statement, timing of intervening and managing MRD really depends on, should depend on a specific time point. And the general consensus here is at end of consolidation as indicated by the International Consensus Consortium statement. And the new COG definition for treatment failure that is used in the 1731 and 32 is a level of 1% or more, or residual extramedullary disease, and similar definitions are to be incorporated in other trials by the BFM and other clinical trial groups. So how does the NCCN guideline give or publish their approach as guidance? So patients that MRD positive post-induction, the guidance is to put them on a clinical trial. However, if there is no clinical trial, to start augmented consolidation chemotherapy. If they become MRD negative, to continue chemotherapy as long as they're end of consolidation MRD negative, and then to continue chemotherapy as the mainstay for that particular population. However, if they're MRD positive, then using immunotherapy is a reasonable approach. Using an approved immunotherapeutic approach as a bridge to transplant is probably the mainstay of therapy for patients not on clinical trials. So in summary, what we know today is that MRD is prognostic. MRD can detect a group of patients that can be treated with low intensity therapy with an almost definite cure. MRD kinetics vary by leukemia, NCI risk, genetic subtype, and immunophenotype. And patients who achieve end of consolidation MRD negativity do relatively well with chemotherapy alone. However, a small percentage of patients have MRD positivity at end of consolidation and are labeled as end consolidation failure. And these are extremely unlikely to be cured with standard cytotoxic chemotherapy. And given the low number of and percentages of patients, it will be difficult to answer this particular question of the best approach, except with trials that incorporate a good number of patients using collaborative clinical trials. And what we don't know today is that would adding immunotherapy to chemotherapy backbone versus transplant or cellular therapy in first remission in patients with persistent MRD positivity would improve outcome. So I would conclude with a suggested approach as of today until we have further information from ongoing trials. That decision for MRD-based treatment assignment should be decided post end of consolidation assessment. Patients who achieve end of consolidation MRD negative status should continue the high-risk chemotherapy backbone. Patients who have end of consolidation MRD levels 1% or above are considered failures and should be considered for immunotherapy versus transplant versus CAR T cell therapy. Patients with end of consolidation MRD levels between 0.01% and 1% should be discussed for best therapy based on the following criteria. If they're NCI standard risk, the suggestion would to continue interim maintenance using high-dose methotrexate and reassess the bone marrow for MRD and continue therapy if negative. If you're NCI, if the patient is NCI high risk, then immuno or chemotherapy is probably best versus immunotherapy and transplant versus CAR T cell therapy as an approach. If you're depending on your cytogenetics, if you're favorable or intermediate, then continue on chemotherapy and assess after interim maintenance 1. However, if you're intermediate or unfavorable genetics, then giving immunotherapy and chemotherapy versus immunotherapy as a bridge to transplant or CAR T cell therapy could be a option for these patients. And these options really depend on access to CAR T cell therapy and availability of a suitable donor. The question is also important. If you have access to CAR T cell therapy, is what if you would collect patients that are end of induction MRD positive to plan for CAR T cell therapy, and if you should plan these patients for bone marrow surveillance at different time points. And with that, I conclude. Thank you very much.
Thank you, Prof. Wasil, and I know we are running a little bit out of time. I will hand over to Dr. Mohammed Sayed to present the next speaker. Thank you.
Thank you, Dr. Isa. It's my pleasure to present our next speaker, Dr. Sumit Gupta, who is a pediatric oncologist and clinician investigator at the Hospital for Sick Children. Dr. Gupta is an associate professor at both the Faculty of Medicine and the Institute for Health Policy Management and Evaluation at the University of Toronto. He is also an adjunct scientist with the Cancer Research Program at the Institute for Clinical Evaluative Sciences. Dr. Gupta is known for his international extensive work with policymakers and oncologists throughout Latin America, Caribbean, and India. He's currently an associate chair of the Lancet Oncology Commission on Sustainable Pediatric Cancer Care. And he's also co-chair of the Children's Oncology Group Clinical Trial for Children with Acute Lymphoblastic Leukemia, ALL 1731. For his outstanding work, he received the Junior Faculty Award from the American Society of Clinical Oncology in 2019. So without any further ado, I would like to introduce Dr. Gupta to present to us the current COG approach in treating frontline pediatric acute lymphoblastic leukemia and the immunotherapy role. Dr. Gupta.
Thank you very much, Dr. El-Assid. It's a real honor to be offered the opportunity to present for the group here today. And even just on camera, I can see friends and colleagues, both current and past. It's nice to see everyone. So I will just share my slides here. Play from the start. So this is going to build nicely, I think, on Dr. Justania's talk that we just heard, which was outstanding as anticipated, but really just maybe taking a higher level as to where the COG is right now in our terms of our treatment of childhood ALL and where we think we may be going in the next couple of years. So for the outline today, I'm going to start by talking just about the basics of COG backbones for treatment of ALL, which I think many are familiar with, so we'll do that pretty quickly. We'll then talk about identifying a subpopulation that achieves outstanding outcomes with minimal therapy. We'll talk about whether we can identify additional populations that have outstanding outcomes. And then finally, can we further improve outcomes in the remaining children? And if so, do we do that by intensifying traditional chemotherapy further, by using immunotherapy up front, or by using targeted or precision or small molecule therapy, whatever you want to call it? So in terms of the basics of COG backbones, so again, everyone in this audience is already going to know that all ALL protocols have induction, post-induction therapy that includes some form of intensification, and then maintenance. So this is a very basic graphic of standard versus high-risk therapy in the COG hands. And though all the protocols in high-income countries, are similar and get you at the same place in terms of overall event-free and overall survival, they all have subtle differences or not so subtle differences, and they all have different advantages and disadvantages unique to that protocol. That's the way I think of it anyways. So in COG, I think one of the main differences is how minimal the treatment is that our standard risk patients get. And Dr. Justania talked about 0932, but it's worth just comparing that standard risk therapy consists of a 3-drug induction, a very light standard consolidation, which is really just 6-MP, some LPs and a shot of vincristine. Intermaintenance 1, which is really just escalating methotrexate. Delayed intensification, some more escalating methotrexate, and then maintenance. On the other hand, children who are NCI high risk or who have high-risk features at the end of their standard risk induction get moved over to high-risk therapy, which you can see here, which is substantially more intensive, even more intensive than, say, BFM treatment, at least in terms of consolidation, for example. Again, just to drive the point home, comparing these two backbones, you can see here that if you are a child who gets COG standard risk therapy, you get a cumulative dose of 75 milligrams per meter squared of anthracycline, 1 gram of cyclophosphamide, and no high-dose methotrexate. And that does seem to make a little bit of a difference. This is a great study from the CCSS group that we're probably all familiar with that basically show that contemporary standard risk therapy doesn't seem to be associated with risks of second malignancies or health-related mortality that were statistically different from the general US population. So for sure, these still are at risk of some late effects, but it seems to be actually quite minor, at least when we're talking about physical late effects. It's also associated with lower healthcare utilization. So a study we did here in Ontario looked at the risks of, emergency room visits or hospitalizations during specific phases of therapy. And what we found that was when you looked at our population-based cohort, pretty much 2/3 of patients were hospitalized at least once when receiving intensified consolidation, compared to only about 30% of patients receiving standard consolidation. So these are big differences. So with that sort of in mind as a background, despite that minimal therapy, can we identify a subpopulation of children with ALL that still has outstanding outcomes? And Dr. Justania kind of showed you that, yes, we can. So when we look at standard risk patients, the event-free survival is quite excellent, particularly for what we call the standard risk favorable subset. And the really simple way that I think of these kids is they have every good risk factor in the book, right? So they are NCI standard risk, they are CNS 1 or 2, they have favorable genetics by the COG definition, which isn't exactly the same as other definitions, but we say ETV6 RUNX1 or double trisomy 4 and 10. They have a day 8 peripheral blood MRD of less than 1%, and they are end of induction flow bone marrow MRD negative. And you can see here, this is graph is for the overall population, but this standard population has a 5-year event-free survival of greater than 95%. And again, this is not a small number of children, right? This is over 1/3 of NCI standard risk kids. So it's a fair chunk of the children that present to us with ALL every week. So in current COG trials, there is no randomized question for these patients. They do far too well to be able to ask a question, either maybe ethically or morally or statistically, frankly. So that's where we are right now. One of the questions, and I won't spend time on this because Dr. Justania did an excellent job of addressing this already, is can we identify additional subpopulations that have those same or similar outstanding outcomes? And this is where we really get into the potential, and I'll emphasize potential, role of high throughput sequencing based MRD. So this is the essentially exact slide that Dr. Justania showed you, which shows that, among previously treated NCI standard risk patients who were end of flow negative, MRD negative, 20% also had no detectable HTS MRD at the same point. And the disease-free survival for these HTS undetectable patients, as we call them, was 98%, right? So just as good as the traditional standard risk favorable kids I was talking about just prior to this. So you'll see what I'm trying to do over this talk is just fit in sort of rationale for the current trials. And for our current NCI standard risk trial 1731, which I have the fortune of being co-chair with along with Dr. Rachel Rao in Houston, like I said, standard risk favorable, no randomized questions, standard therapy. For standard risk average patients, which are ones that don't meet standard risk favorable criteria, so they're not the best of the best, but they don't have any of the traditional adverse prognosticators we're all familiar with, flow MRD positivity, unfavorable cytogenetics, we are further risk stratifying those by their HTS MRD negative status. And if they are HTS MRD negative, then they just get standard therapy so that we can prospectively verify what we think is, based on that retrospective data, an outstanding outcome for this group. So again, when we talk about in COG, trying to identify further groups that have outstanding outcomes, one of the ways we're doing this is by betting on HTS and seeing whether that allows us to do that or not. So The big question, though, is can we further improve outcomes for the remaining children? And we really have three potential ways of doing that: further intensifying traditional chemotherapy, immunotherapy, or targeted therapy. So when we talk about traditional chemotherapy, I think it's worthwhile just having two quick slides about some positive versus negative trials in the recent COG history, where we've tried to intensify or optimize traditional cytotoxic chemotherapy. So here you can see a list of trials where we did that and it worked, right? And you can see from the numbers that these are mainly 2-generation ago trials or 3-generation ago trials. And I won't go through the details here because I think many people are familiar, and Dr. Justania went through some of this as well. But here are a list of questions or trials in COG studies where we tried to intensify therapy, where we had negative results. And you can see that these are most of the trials that were in the last generation as well. So both in 2 generations ago in standard risk, trying to intensify consolidation or add pegosparaginase, or as Dr. Justania alluded to, intensifying consolidation further on 1131, these really haven't worked. So the sense that I think we and many other cooperative groups are coming across is that we have probably reached the limit in terms of what we can intensify and how much benefit we can get from further intensification for our patients. So then that leaves us with these two other strategies, the most exciting of which, as we all know, is probably right now immunotherapy. So currently, the strategy in COG-ALL is to study whether incorporating immunotherapy into first-line therapy of B-ALL improves outcomes. And so what we've done is take each of the immunotherapies that we think are most exciting and by their sort of side effect profile, slot them into different groups of ALL patients. Blinatumomab for standard risk, inotuzumab for high risk, and CAR T cells for very high risk. And we'll briefly touch on these and what I mean by that. So starting with standard risk and blinatumomab. So I think it's first important, because I've had to justify this, and we've all had to justify this to ourselves and others, why study a novel agent in standard risk B-ALL? After all, I just told you that most of these patients do actually quite well. So one reason is that despite the overall good outcome, because this is the most common subtype of ALL we see, half of all of our ALL relapses still occur among NCI standard risk patients. And as I alluded to before, intensifying traditional chemotherapy doesn't seem like it's going to work for this population. We tried more asparaginase, we tried to intensify consolidation, we tried a higher dose of methotrexate in maintenance, and none of these things resulted in a substantial improvement in outcome for NCI standard risk patients. So therefore, it really comes to further improvements are going to require probably novel agents. So we really have two choices. We can either say, we accept what the outcome is for these patients right now, and we don't think we can improve further, or we try a novel agent. And there are pros and cons to both of those strategies, but it probably is a little bit black and white like that. However, if we are going to try a novel agent, given the overall favorable outcome, that agent has to have both good evidence of anti-leukemia efficacy and also have a favorable toxicity profile. So we were lucky in that when we were coming up with this trial and coming up with the question, we did have an agent, blinatumomab, that sort of met those criteria. So again, we're probably all familiar. Blinatumomab is a bispecific T-cell engager that targets CD19, which is found on virtually all B-ALL surfaces. There was encouraging initial results in the relapse refractory setting in both adults and children. Some of the references are there for you, but we're not going to spend time going through them. And then there were a series of trials that suggested that blinatumomab efficacy might be maximized through their use at earlier disease stages and lower levels of disease, and similarly showing evidence for efficacy of MRD clearance. So the BLAST trial was the quintessential New England Journal adult trial that showed that MRD clearance was something that blinatumomab was actually pretty good at. At the same time, as I mentioned before, it also has a generally favorable toxicity profile. We're probably all aware of cytokine release syndrome and neurotoxicity, but those tend to be pretty rare, particularly in patients who have low levels, and particularly MRD levels of disease when they are given their blinatumomab. These are really important results that I think we're all familiar with because they're a couple of years old now. But we did find in COG that in pediatric first relapse BAL, that patients with high risk relapse after receiving their initial reinduction chemotherapy, who were randomized to either receive 2 further courses of intensive chemo versus 2 courses of blina did have superior overall survival, and on a one-sided test, disease-free survival as well. And our European colleagues showed the same thing, and these are 2 beautiful papers published side by side in JAMA, as you can see there. So this made us excited for blinatumomab in this context. So remember I told you that the standard risk average patients, if they're HTS negative, they just go and get regular therapy, no further question besides just making sure they do really well. The NCI standard risk patients who have higher risk features, either traditional ones like unfavorable cytogenetics or flow MRD positivity at the end of induction, or this potentially novel one like still being HTS MRD positive at the end of induction, they got randomized to standard therapy, whether that's standard risk or high risk backbone, versus standard therapy plus 2 intercalated courses of blinatumomab, as you can see here. I'm not going to spend much time on this, but high-risk Down syndrome patients, given their increased risk of toxicity, are non-randomly assigned to a backbone in which blinatumomab replaces some elements of standard chemotherapy, trying to take away some of their toxicity while maintaining or hopefully even improving their disease-free survival. We are not the only group, obviously, studying blinatumomab in newly diagnosed ALL. The AFBFM folks are, St. Jude's are, though generally in a higher risk population than we are in COG. Just really quickly, other considerations, there's quality of life that we're trying to measure that might be associated with continuous infusions, which we know blinatumomab is, obviously. There are cost considerations, particularly for those of us who practice in single-payer health systems. And since CD19 negative relapse is a known cause of treatment failure amongst patients receiving blinatumomab, and given the existence of other CD19 dependent therapies, we're really monitoring closely the incidence of CD19 negative relapse on our study. Okay, so that's blinatumomab. These other 2 we're going to go through in a more short form way. So inotuzumab in the context of high risk therapy. Again, I suspect we're all familiar with this. Inotuzumab is a humanized antibody against CD22. And that's taken into the cell, it's conjugated, linked to calciumycin, which is cytotoxic to the cell. It's taken in and hydrolyzed, and then it does its job. Again, much like blinatumomab, inotuzumab has also recently, not so recently anymore, had good evidence in the relapse refractory setting in both adult settings, i.e. the INNOVATE trial, which I've referenced there, and in pediatric settings as well. Sinusoidal obstructive syndrome, that we used to call VOD or veno-occlusive disease, remains a significant concern. So that's why, given that concern of a maybe more significant toxicity profile, this was the agent that was chosen to take forward in 1732, which is for NCI high-risk patients, led by doctors Jennifer McNear and Maureen O'Brien. In this group, in this study, those who have high-risk favorable disease should have excellent outcomes. They're young kids who have favorable cytogenetics and are end-of-induction MRD negative. So those get siphoned off and just treated non-randomly with standard therapy. And everyone else gets randomized to standard therapy versus standard therapy plus 2 courses of intercalated inotuzumab. It has a safety phase, which has currently been completed, and we're just waiting for those data to come in, and then it'll be hopefully reactivated for an efficacy phase. Obviously, close monitoring of sinusoidal obstructive syndrome is going to be key on this study, and is key on this study already. And then finally, CAR T cells for our very high-risk population. So this is, Dr. Justaniev set me up really nicely for this in talking about what we know are the quite poor outcomes for NCI high-risk patients who remain flow MRD positive at the end of consolidation. You can see that 40% statistic that he put up as well. And so we're also all aware with how exciting CAR T cells have been over the last 5-10 years or so. So what 1721, led by Dr. Shannon Maud, attempts to do is see, instead of taking those NCI high-risk patients who are end of consolidation positive and sending them to transplant, which would have been standard, do we improve or maintain their outcomes if we send them to CAR T cells as well? So these patients, if they are end of induction MRD positive, then go on to screen if the parents and the physicians so choose for this study. And then if they remain positive in terms of flow MRD at the end of consolidation, then they actually are leukapheresed manufactured CAR T cells and then given CAR T cells. If you have a really high end of induction MRD greater than 1%, we know you're probably going to be positive at the end of consolidation as well. So those patients we collect earlier. And that study is about halfway through its accrual, so it's accruing nicely, and hopefully we'll have answers in the not so distant future. Okay, so we talked about further intensification of traditional chemotherapy probably not working. We've talked now about immunotherapy, and then finally just a few short words on the role of targeted precision or small molecule therapy. And again, these are just examples. I know Dr. Biondi's already talked substantially about what's happening with pH positive ALL, and so there's further efforts there, and he and Dr. Tai Tran and Mignon Lo and many others are involved in an international collaborative trial of Abel class mutated newly diagnosed ALL. And then Dr. Sarah Tajian is very close to finishing accrual of AAL 1521, which is studying the addition of ruxolitinib to patients with newly diagnosed PH-like ALL, pardon me, that have JAK-STAT pathway mutation. So again, each of these is a talk in and of itself, but just to know that all of our eggs are not in the basket of immunotherapy alone, that there are these very exciting targeted therapies that continue to be studied both by ourselves and more often, given the rarity of these patients now, in collaboration between ourselves and our European colleagues. So in conclusion, we already know, even without immunotherapy and without targeted therapy, that we can identify a subpopulation of newly diagnosed children with ALL that has achieved outstanding outcomes with minimal therapy. New techniques such as high throughput sequencing measured MRD may help us identify additional populations with outstanding outcomes. Further improvements in outcome for the remainder of children are unlikely to result from further intensification of traditional chemotherapy. And the main current challenge for us is to determine how novel immunotherapy and targeted therapy can be best incorporated into standard therapy to maximize further improvements in the outcome. And international collaboration, as you've heard, I think, again and again, multiple times today, is going to become increasingly important, if it's not already, in achieving these goals. A massive number of people need to be thanked. Some of these slides belong to them, some are my own, but the work these slides describe is in huge part due to the people on this screen and dozens of others as well. And with that, I think there's a Q&A afterwards, not now. I may not be able to stay for that just because I'm still in clinic, unfortunately. And because we're running a little bit late, I might have to sneak back down to clinic. But
thank you so much, Dr. Gupta. Would you be able to take one question for us?
Of course, yes, I'd be happy to.
So we have a question that what do we do in a case of standard risk B-cell ALL? End of consolidation positive MRD or MRD between 0.01 and 0.1, no available clinical trial.
Yeah, that's an excellent question. I think Dr. Justania mentioned this a little bit. It is controversial. Dr. Justania mentioned Dr. Rao's paper in PBC that looked at the outcomes of these patients and actually was better than most of us would have anticipated, I think. Some caveats I'll put onto that paper, which the paper mentions as well. It's not like these are unknown. It's a small number of patients, so the confidence intervals are quite wide. And it's not as if these patients remained on a clinical trial, so we know exactly how they were treated, right? So some of these patients may have gone on to transplant, as many people were doing with end of consolidation positive patients in general, right? So we don't actually know what treatment they got afterwards, so it's really hard to make conclusions about that patient group. What I will say, and this is not based on evidence, is, I often think of ALL as a score, right? Like you get good points and you get bad points, right? So the patient who is a 4-year-old whose MRD positive at the end of induction wasn't that bad, who has favorable genetics and is 0.02 at the end of consolidation, I'm probably going to think very differently about that kid than the 9-year-old who has IM21, who has end of consolidation 0.05, right, or 0.09. So, is there evidence to guide exactly what you should do with either of those patients? No. But, I think in the first one, I'd be a lot more willing to entertain chemotherapy only and watch and see how they do. Also knowing that we have these backups of immunotherapy in the relapse setting now as well, versus the latter one, I'd be a lot more hesitant about just going forward with chemotherapy as well. So I think we have a fair amount to learn still about that situation.
And thank you so much, Dr. Gupta, and we really enjoyed your talk. Thank you.
Thank you for the opportunity.
Thank you. So it's my pleasure to present our next speaker, Dr. Todd Michael Cooper. He's an attending physician at Seattle Children's Hospital and a professor of pediatrics at the University of Washington School of Medicine and Evans Family Inwood Chair in Pediatric Cancer. Dr. Cooper is also the director of the Pediatric Leukemia Lymphoma Program and co-director of the High Risk Leukemia Program. His interest and expertise focus on the development of new therapeutic strategies for treatment of children with acute leukemia. He serves as a chair of the COG Acute Myeloid Leukemia New Agents Committee, and he's leading COG new study AAML 1831, which is a phase 3 study for newly diagnosed children with acute myeloid leukemia. He's also a clinical trial lead for Leukemia Lymphoma Society funded master trial for relapsed pediatric acute leukemia. So Dr. Cooper will talk to us about updating the risk classification in pediatric child with myeloid leukemia over the next half an hour. Dr. Cooper.
Yes, thank you so much. I hope you can hear me well. I can't begin to tell you how honored I am to be asked to present to this Congress. I really, really appreciate it. I'm happy to be able to talk about pediatric AML. The speakers thus far have been outstanding, focusing on childhood ALL, and I look forward to talking to you about updating the risk classification in pediatric AML and the Children's Oncology Group experience as it relates to the current phase 3 trial, and also have a couple of slides at the end that introduce this Leukemia Lymphoma Society pediatric master trial for relapsed acute leukemia as well. So first, I will give very brief background, very brief, because I think most people on this wonderful Congress already know this information. Unfortunately, we are lagging behind our colleagues in the ALL world in terms of overall survival. And one of the reasons here is our therapies really are largely unchanged, unfortunately, even since the 1970s, when it was first introduced, the 7+3 of cytarabine and anthracyclines. We have made some strides, but these strides have basically been because of maximal intensity of chemotherapy, because of stem cell transplantation, and because of we're getting better with supportive care. I do have listed in this slide the inclusion of a targeted therapy for AML that's now FDA approved in the United States, gemtuzumab, the CD33 antibody, and that has resulted, as I'll show you in 1 second, in some improvements. So this is a Kaplan-Meier survival curve of the North American studies since really the 70s. And you can see here that there have definitely been, because of clinical trials and everything else we discussed a second ago, there have definitely been improvements. One of the biggest of which was right here, the 2891 study led by Bill Woods, which did intensive timing chemotherapy. And you can see here that was quite a leap. However, we instituted a MRC backbone here, an AML03P1, which was the pilot study for gemtuzumab, and 0531, which was the phase 3, which also resulted in improvements. But our last clinical trial, AML1031, really did no better, and in fact might have been a bit worse. I don't have time to talk about why, but in general, there's a few reasons, and one of which is we de-escalated the cytarabine quite a bit in AML 1031 by skipping our last intensive cytarabine cycle. So obviously we need to do better. And I'm going to focus just on one way that we can do better, and that is assigning patients to the correct therapies. Before I do so, I do want to briefly, very briefly, go through these last two COG phase 3 trials and point out two things. Number one, you can see increased complexity between the AML 0531, which incorporated gemtuzumab, and the AML 1031 trial, which incorporated bortezomib into the standard backbone. But also this trial did test a FLT3 inhibitor, sorafenib, which is accepted for publication, and these results have been outstanding. What I also want to point out on this slide is the relative simplicity of the risk classification, which you can see here and here. And basically, the high-risk features had not changed over these two prior phase 3 trials. The low-risk features hadn't, and really the only difference was rather than having 3 risk stratifications in 0531, there were 2 in 1031, and that is due to the incorporation of minimal residual disease by central flow cytometry into this. So in contrast, we see the current phase 3 trial, of which I'm the chair, and I say that because it's almost apologetic in a way, because it's an incredibly complex study, which a lot of that surrounds the risk assignment. But this particular clinical trial randomizes patients between a backbone of cytarabine and daunorubicin plus Mylotarg versus liposomal cytarabine and daunorubicin and CPX-351, also known as Vyxeos, plus Mylotarg. In addition, this also allows for incorporation of a FLT3 inhibitor, not only for our FLT3 ITD patients with the high allelic ratio, but also, as I'll describe in one slide a little bit later, we've incorporated the addition of gilteritinib, which is that FLT3 inhibitor for both of these arms, for FLT3 activating mutations that are not driven by the internal tandem duplications. And importantly, what we'll focus on mostly is this risk assignment that occurs after the first cycle of induction chemotherapy. So in order to understand our risk classification, we have to understand that, and I think everybody on this Congress knows, that childhood and pediatric AML are not the same. They are biologically distinct, and we have continued to make this case both nationally and internationally to our regulatory authorities and also to our pharma colleagues. And what we've been able to determine is that the younger you are in pediatric AML, the more likely you are to have an AML that is driven by fusions rather than mutations. And this is the top panel here is from Catherine Tarlock and Sohail Mashinchi. This has since been published, but this is based on Foundation Medicine results from clinical trials and is retrospective. And then we also see here in this panel the adult TCGA whole exome and genome sequencing versus the target AML, which was whole genome sequencing as well. And what you can see here again is a much higher prevalence of the fusions in children versus the mutations in adults, such as your IDH mutations and the DNM2As, etc. In addition, from this target initiative, we also found new fusions and other abnormalities that are driving pediatric AML that have terrible outcomes, which we have listed here are CBF GLIS2 patients, our ETS fusions, our KAT6A fusions, and also our NUP98 fusions as well. And not just with our KDM5As and NSD1s, but as will be published very soon, I think it's been accepted for publication, US and European collaborative showing that really any NUP98 fusion does quite poorly. In addition, I wanted to show you this, this contrast from adults, whereas the tyrosine kinase domain mutations that we often see in adults, the TKD mutations, the D835s, are present in adults and they are present in children as well. However, in contrast to adults, we also see other tyrosine kinase and non-ITD AML driving mutations as well. And you can see here on the right panel, Drs. Mashinchi and Tarlock also added crenolinib to patient samples, and we are seeing that these mutations do respond to FLT3 inhibition, and this is why we have incorporated this into our pediatric trial. So I wanted to give you the rationale or some of the lead up to this change in risk stratification. So what we did is we went back to these last 3 phase 3 studies within the Children's Oncology Group, and we did central review of clinical karyotyping in fish, our molecular alterations, and then used the target data as well as individual RNA-seq and qPCRs for specific fusions to find additional risk stratifying lesions. And what we did, and this isn't universally accepted, but we basically said any of these fusions by which had an event-free survival of less than 50% is high risk. And what we did was, and you remember how simple that risk stratification was in the last 2 phase 3 trials. Now look at it. There's a number of new fusions and mutations that are added to this list, including our MECOMs, our DEC-NUPs, which we often see with our FLT3 mutations, our KAT6As, FUSE-ERG, GLIS2, and this is a biggie, and this is what we're seeing a lot of on the current phase 3 trial. There are a number of KMT2A mutations that have been added to high risk, and these patients do extremely poorly. In addition, the MLL-T10s with any partner gene do extremely poorly as well. Obviously, our FLT3 ITDs with high allelic ratio, our RAM phenotypes, which go with our GLIS2, and then really our MRD positive patients as well. Our favorable prognostic markers really have not changed much. But before introducing this into the next phase 3, we went back to the last 2 phase 3s to see what sort of impact this would have. This was presented at ASH, and manuscript has been submitted. And what you can see here, if we apply these criteria to the retrospectively to the 0531 study, before adding MRD, 31% of the patients were high risk. After entering MRD, 40% of the patients were high risk. And you can see in contrast to the 13% that were high risk on the actual study. And then obviously the survival curves are sussing that out and showing that these patients do extremely poorly. We wanted to validate that, and we did that by going back to the AML 1031 study. And you can see with the addition of FLT3 and MRD to 1031, 30% of those patients were high risk on the actual protocol. And when we put these criteria into the 1031 retrospectively, 41% were high risk. So putting it into practice, we were able to move these high risk criteria through protocol development, and these high-risk criteria are now incorporated into the study. There are 3 risk groups. Those patients who have favorable prognostic cytogenetic and molecular markers with negative minimal residual disease get 4 cycles of chemotherapy, because even on that last trial that didn't do as well, those patients that had these features actually did quite well. Our high-risk patients, which now is a much larger group, receives stem cell transplant. It says here 3 cycles of chemotherapy, but we're allowing patients to go to transplant after 2 cycles of chemotherapy. And then everybody else receives 5 cycles of chemotherapy, basically per the arm of AML 0531. So 5 cycles of chemotherapy. So we have 3 risk groups once again. Now, this is where I think that this is one of the great things about this trial, is that this diagnostic testing, while quite complicated, is actually wonderful because there are eyes on every piece of this centrally. So obviously sites are doing their local cytogenetics in fish, but this is reviewed centrally by our team of study hematopathologists and cytogeneticists. In addition, a sample is sent to hematologic, so central flow cytometry review at diagnosis. So they are performing baseline flow cytometry so that they can accurately have that baseline moving forward for their end of induction 1 and 2 responses. And then they're also looking at the RAM phenotype, which thus far has gone along perfectly with our GLIS2 fusions detected by Foundation Medicine. In addition, patients are sending, the sites are sending samples to the Biopathology Center nationwide, so centrally, where they are extracting DNA and RNA, and then they're sending it to a number of other laboratories for further interrogation of these samples. One is sent to Fred Hutchinson Molecular Oncology, which is centrally reporting the FLT3 ITD with allelic ratio testing. They're also the source of truth for the study for our NPM1s and BZIP CEPB alphas. And then another sample, both the RNA and the DNA, is sent to Foundation Medicine, who first, within 10 days, are reporting those FLT3 non-ITD activating mutations back to the sites. And then second, they're reporting their RNA and DNA sequencing, both in a study-specific report and then also a CLIA laboratory report back to the sites. And you can see here, here's one of a couple of different schemas of how we're incorporating everything. You can see molecular oncology, Foundation Medicine, local cytogenetics and fish, and hematologics are all reviewed. And one of our other study committee members, who's very computational, Matthew Cutney, helped to put together this AML risk matrix. And this is all automated. So either the laboratories for 4 out of 5 of these are directly entering this data into a variety of case report forms, or the site, in the case of the Foundation Medicine activating mutation, are reporting this into a case report form. And then what happens is you have a centrally automated risk group assignment, which then goes back to the site and tells them they're either LR1, LR2, or high risk. And that is done by the end of induction 1, with the addition also of your minimal residual disease. And so again, this is all reviewed centrally by all of us and then forwarded to the site. There's sometimes a lot of back and forth, but it has worked out incredibly, incredibly well. And it's something that we're all very proud of thus far in this study. And you know, if you go back and look at what we projected on the past 2 phase 3 trials to be the number of high-risk patients, thus far, we're very, very close to that. So 43% of these patients are high risk, 37% are low risk 2, and 19% are low risk 1. So, so that's mostly our risk stratification for newly diagnosed patients, but even so, and we hope that we're getting those patients to the right therapies and we're intensifying therapy via transplant for more patients, and hopefully we'll get better outcomes. But still, we expect that a large number of these patients are going to relapse. And as we all know, these patients need better approaches, and we all need to come up with a way to all work together for these patients and also have longitudinal data collection from diagnosis to relapse. And we hope that this can be moved forward by this initiative that we're all very excited about, the Leukemia Lymphoma Society Pediatric Acute Leukemia, or PEDAL initiative. They did this in adults, called Beat AML. This to me is a much more complex thing because this is going to be a collaboration between the United States, North America, Europe. Also, we expect Australia and New Zealand to participate in this. And what this is it'll be the first comprehensive international study that will very systematically collect information and provide data on targets for children with relapsed leukemia. And I'll show you how we're going to do that in just a second. But this is quite important. It's very, very difficult to accrue rare subsets of patients onto a trial. if we're doing it piecemeal. We have to come together to be able to do this nationally and internationally. And through such of an effort, and with the support of Leukemia Lymphoma Society, it would be great to bring our pharma partners to the table so that they'll have a mechanism to accomplish this. And hopefully we'll bring these drugs to children earlier. And also our regulatory authorities are involved in this, and prospectively we're running everything by them, because we want these companies to be assured that they'll get the information they need for approvals and fulfill their regulatory obligations. So the backbone for this in North America is this what we call a screening trial. And the way this happens is if you have a patient that so you put this screening trial through your IRB. There's no treatment on the screening trial, so it should go through fairly quickly. And if you have any newly diagnosed patient, or any relapse patient or any suspected relapse patient, and that's very important because these are the patients we're missing. What's happening in real life is that we suspect a relapse and we do a marrow, and only then do we start to try and figure out what trial they should go on. And what we want to collect is these suspected patients earlier. So confirmed or suspected patients can enroll on the screening trial. They submit specimen. They also submit via case report form a lot of other clinical data. And then these samples will either go centrally to hematologics, which will confirm the relapse and report the blast percentage. And they also will report sub-trial target markers. So there's sub-trials associated with this screening trial for which these patients can be assigned. The blood or bone marrow will also go to Foundation Medicine, and those patients with greater than 10% blasts will be sequenced, and these will also go into the database. And what you can see here, this is another very large schema on how this will work. We'll have all this data from 1831, so we'll be able to connect this longitudinally to relapse. Patients go on the screening trial. Most of these patients will have been on the phase 3, but we're collecting those that aren't and their clinical data. All their data from Foundation 1 and hematologics will go into this tool that's been developed by Sam Bolchenbaum and his group at University of Chicago, which will take all this information and tell patients what trials they're eligible for. We are not assigning them, at least not in North America, because that hasn't worked in the past. I don't have enough time to go into it, but there's already 5 or 6 trials that are pretty close to being activated. And the screening trial has already been approved. So we're very, very excited about this. And what Leukemia Lymphoma Society has done is linked the Children's Oncology Group Network and also what they're calling the UPAL Consortium, which is a number of existing consortium throughout Europe that we're really excited about. And so we're working together not only on these screening trials, but also on international trials moving forward. So we're very excited. So in conclusion, AML still has an overall poor prognosis, devastating side effects, and we need to move forward, like our ALL colleagues, with more targeted therapies. The current phase 3 utilizes a risk stratification based on standard techniques as well as next-gen sequencing, and that it's a very coordinated process using central review that will hopefully assign patients to their proper therapies. And those that need more intensification, such as transplant. And then finally, the LLS PEDAL initiative. I just wanted to introduce that to everybody here because we're very, very excited about it for our relapse. And it's not just AML, it's ALL as well, certain subsets of ALL. And we're excited about that trial as well. So again, there's a very, very large number of folks that we need to acknowledge here, both from PEDAL, Leukemia Lymphoma Society, COG, our European colleagues as well, and also our regulatory authority colleagues, and also our pharma partners as well. So thank you so much for the opportunity to talk to you. I really, really appreciate it, and I'm honored. Thanks.
Thank you very much, Dr. Cooper, and thanks for all the speakers and your all putting on the cameras. I know we're running out of time, but we have questions, and actually we'll start with the last question I can see with the last talk, but we have also plenty of questions for Prof. Biondi as well. So for Dr. Cooper, in centers where there are, the MRD is not, validated, harder than the ALL. It is always the question about two categories of patients: the low-risk patients that you recommend 4 cycles versus 5 cycles based on MRD assessment, and also the other intermediate risk group, where what's so-called intermediate. Previously, we will take them to transplant if there is a match-related sibling. It is always a debate in some centers, and would in the future the NGS get rid of the MRD and such with the new molecular and the more unfavorable, AML categories?
Yeah, I mean, you or whoever asked that question definitely are touching upon a very, I don't want to say controversial, but let's just say difficult question as it relates to minimal residual disease. So, we felt like for the trial perspective, it was important to have central MRD so that the data can be as clean as possible. The issue that I see in full transparency and honesty is that hematologics, it's excellent. It's been used for the last 3 really phase 3 trials. It uses a difference from normal technology rather than leukemia-associated immunophenotypic profile. So this technology, while they're moving it forward through the FDA, and so everybody can get it if they want it, we have definitely seen, because sites are submitting MRD to hematologics, and then they're also doing it locally. Many are, and then we don't always get the same result. And so we've definitely seen cases where, hey, hematologics is negative, but we're positive. What do we do? And I usually say, well, you're supposed to go by hematologics, but just wait 2 weeks and repeat it and see where you're at, because it'll eventually show itself. Now, the other question you ask is, what about other techniques like next-gen sequencing? This one's going to be very tough. We are doing a lot of correlative biology that will not be transparent through the study until after the study is done to learn more. But it's really hard because these are not great MRD techniques for most abnormalities. I know in adults, they're using PCRs and other techniques for nucleophosmin, NPM1, but it really depends on the fusion or the lesion, and then the level of detection is all over the place, from 1% to 0.1%, etc. I think that's going to require very careful study and collaborative study in order to come up with real answers. But as long as people are sending next-gen sequencing to 10 different laboratories, it's going to be hard to come up with a single answer. I have a patient myself with NPM1 positive who's low risk, but had some MRD in the beginning, but that NPM1 is still detectable after 5 cycles at 0.002 or something like that. And I'm just following this patient with NPM1 PCRs. But I didn't take the patient to transplant, so maybe I did the wrong thing. I just don't know. But until we get these answers and can do it in a collaborative way, I think it's just going to be a bunch of one-offs and is less than effective. Great question.
Great, thank you. I can move to Dr. Biondi in the same theme, because you mentioned a positive PCR, and then when you talk about pH positive, and still people get those results sometimes, a positive, and it was shown and described by Prof. Wassel and Prof. Biondi about not relying on pH, the BCR-able PCR, in the decision of transplant and response. But any comments, Prof. Andrea?
Well, thank you very much, Esa. You touched upon another controversial issue, as Todd replied very well on AML. Because first of all, in the adult setting, the standard monitoring a pH positive LL based on the experience of the CML is by using the RQ-PCR of the BCR-ABL. and in most of the case by using peripheral blood instead of bone marrow. On the other side, the ALL pediatric landscape was used to refer for most of the ALL to the clonotypic marker. Okay, that's the historical background of the controversial issue. Then it became less frequently than expected, I have to say, to receive email from to highlight from the clinicians that highlight the discrepancy between my patient is still positive by RQ-PCR, but negative by IG and TCR clonotypic marker. Then it came out the Yanzuna paper, the Czech paper, and the editorial that Steve Unger wrote on the blood issue that reported that paper. So I think it's still a very open issue. On the other side, we need to say that in most of the case, or very rarely, you might have a pediatric Ph positive ALL with a history of CML. Because in that case, of course, it's relatively easy to say it's a blastic crisis of a CML. But it's not the P210 transcript that may distinguish the two forms. And I think on the clinical standpoint, as one of the query raised, this could be relevant. Because although the number of cases reported by Czech colleagues was limited, the outcome of the CML-like are those who took benefit of the bone marrow transplantation differently from the pure Ph positive ALL. So we are actively working together within the ASFAL consortium, and we are going to update the results of that preliminary was reported by Yanzuna. And but the biological hints behind these differences is still unknown. But honestly, if you ask the question, should I continue the treatment with TKI after the end of treatment, 2 years treatment of ALL? My personal advice is to say no. There is no rationale to do that, even because you don't know when to stop it. And accordingly, what is the reason to provide the potential toxicity of continuing giving the TKI? But as Todd said, maybe I'm wrong. So we need to be aware of that. But on the other side, there is no rationale to continue because there is no evidence that even you can prevent the relapse of ALL or Ph positive ALL. If you continue after the 2 years time, even in the presence of the BCR-ABLASON RQ-PCR test, the occurring relapse.
Great. How about, there's a question about the use of blinatumomab in someone who got toxicity during the standard of care outside the clinical trial. Do you see a benefit, in upfront setting rather than the relapse?
Well, this is a very good question, and the answer is that we have no, so far, as Gupta mentioned in his presentation, we are still lacking whether the substitution of chemotherapy blocks with blina, either in the standard risk or in the high risk, according to the COG and the IOPFM, can really provide the same results with a lower toxicity. So in that sense, of course, if you don't have alternative today and you have a very high profile of toxicity, it could be a reasonable way. But again, as you know, the way to treat individual patient doesn't teach you a lot. And so this is probably one of the important lessons of the pediatric oncology community as compared to the adult. If you consider that we were in the position in the early 2000s to perform a randomized study comparing the imatinib, when already at that time most of our adult colleagues were already used the TKI plus chemotherapy. So in that sense, if you have no alternative, I would suggest to say yes, but it's more important to keep the patient on trial.
That's great. A question to Prof. Wasil about the HTS incorporation at the national level. How would you look into that in the future with collaboration or other options that could help us in Saudi Arabia? For MRD. Hello, Dr. Wasil. Yeah, I'm afraid Prof. Wasil is not hearing me.
Sorry. I somehow got disconnected and talking. Thank you for the question. I think if I'll just repeat your question because I missed some of it. So your question is that using NGS as a method for MRD at the national level. I think one of the challenges we have nationally is validation of MRD. Different centers are using different standards for MRD measurements. Although majority are using flow cytometry for MRD measurement, the methods used are variable between centers, and the number of colors of flow are different from one center to another, and some are using PCR. So I think as a motion to standardize MRD testing nationally, I think clonoSEQ NGS method may offer an opportunity to have a similar MRD assessment between centers that would help us move forward. So I think it is a method that probably would help solve some of this validation and standardization issue between centers nationally, since we're not on a clinical trial and do not have a central lab to test for MRD.
Last question to Dr. Cooper about the current AML upfront therapy and the current open study incorporate the liposomal CPX and plus Mylotarg as part of the backbone. In the absence of availability of the liposomal, and we can see that the etoposide was taken out of the current standard of care, maybe following the MRC. But again, what would you recommend the standard of care right now for AML therapy is AD or DA plus go without etoposide that's a general question.
Another great question. Very insightful. Yeah, when we put the study together, we used the rationale that a prior MRC study, I believe MRC 15, randomized ADE versus DA in induction 1 and didn't find any difference in survival or even response, but that was by morphology. And we use that as rationale to do DA plus Mylotarg, saying that not only that study, but intensifying with Mylotarg, should make up that difference. And, it was accepted, and it made it easier to randomize the cytarabine and dono in a liposomal plus Mylotarg versus free drug plus Mylotarg. I will say again, in full transparency, no idea, right? If our standard arm is going to do as well as the last standard arm thus far. This was a watch item, okay? That's being followed very closely by the DSMB. It's early. We're about 350 patients in out of about 1,400. So don't know, but thus far we haven't been told to stop. I will say that at our own institution, we use the best, the last best possible published data in North America. So it's ironic that I also, if they say no to the study, I'm giving ADE plus go in full transparency because I don't know any better. But we hope that you know, it's not doing any worse. That's a great question.
Thank you all. Actually, I'm getting notes here. You have to stop, and we don't want to stop. But that's the end of the session. And actually, we really enjoyed the talks from everyone on the podium. And really, we would love to have it again and again in the future and further collaboration. Thank you all for the beautiful session.
Thank
you
you.
very much, everybody. My best to all.
Thank you.
Thank you all.
Thanks. Bye-bye.
Live? We are live. The floor is yours. Thank you.
Okay, assalamu alaikum. Good evening, everybody. We'll go now to the next session, which is the other part of non-malignant part of today's session. So we enjoyed 4 excellent talks about acute leukemia in children. So now we will be having 3 sessions covering non-malignant hematological disorders. Dr. Ali Al-Ahmari, pediatric hematologist oncologist, supposed to co-moderating this session with Dr. Aman Al-Gufaydi, but actually Dr. Aman Al-Gufaydi was not able to connect with us today, unfortunately, so she is sending her apologies for everybody. So I will take care, inshallah, of the moderation. Next talk, I just want to ask this speaker kindly to stick with the time because we are already behind, and we will defer all the questions till the end of the sessions, and we will be happy to take your questions. So if you have questions, just drop it in the chat box, and we will be happy to take it at the end of the session. So without further ado, let us introduce the first speaker. So it gives me a great pleasure to introduce my colleague, Dr. Al-Jifri. Dr. Al-Jifri is well known to all of us. He is a senior pediatric hematologist, oncologist, and transplanter at King Faisal Specialist Hospital in Riyadh. Dr. Al-Jifri, he is really a main contributor to the national effort in treating hemoglobinopathies as well as bone marrow failure disorders, especially in stem cell transplantation. So without further ado, Dr. Al-Jifri is going to present us today bone marrow failure syndrome. So Dr. Al-Jifri, the floor is yours. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Ali, for the introduction. Today I'm going to talk about inherited bone marrow failure with considerations or special consideration in regards to stem cell transplantations. I would be reflecting more on the transplant side rather than going in details about the disease category. We know that the bone marrow failure, especially the inherited bone marrow failures, are heterogeneous group of diseases. They are complex in nature, and they are known to have ineffective hematopoiesis and developmental abnormalities, and they have predisposition to cancer. We know that the underlying cause is genetic mutations that are known. Some of them are known for a long time. Some of them are being studied more and more. And these genes play an important role in the development, function, and maintenance of the hematopoietic tissue and the immunological functions. As you can see in the screen, the integration of these genes and the overlap among them in playing different roles, as you can see in the immune deficiencies, the pancytopenia, the single line cytopenias, and dyskeratosis. So really, it's really quite variable when we talk about the clinical and hematological, immunological manifestation. They're really intermingled with autoimmune manifestation, immune deficiencies, and the variable sort of bone marrow failure. And as you can see, the disease such as dyskeratosis congenita, Fanconi anemia, Debon-Blackfan, and Schwachman-Diamond, as well as congenital neutropenia and new syndromes that were described like GATA2, SAMD9, and SAMD9L, and MECOM, ligase 4, etc., etc. So we know that the curative disease for most of these diseases are stem cell transplantation, and finding a fully matched donor may offer the best outcome in these patients. However, mismatched donors may be associated with high risk of GVHD, rejection, and immune abnormalities. It's very important to make an accurate diagnosis if you are faced with a patient with bone marrow failure, because that impacts on the management of these patients, especially if you talk about chemotherapy or transplant. Another important factor is when you screen for potential donor, especially when it's a sibling or related donor. You need to screen also for the underlying genetic abnormality, especially the molecular diagnosis, because the manifestation of disease can vary even among family. The hematological or physical manifestation can vary among family. Therefore, it is really important to screen for these abnormalities. The long-term follow-up is important, considering in mind that these patients are prone to develop cancer or prone to develop organ dysfunction. Therefore, it's important to look for the organ function and follow up and screen for cancer. Now, with the knowledge of more and more, syndromes like MECOM, which is a syndrome known to have bone marrow failure, cardiac, renal, and hearing abnormality, together with immune dysfunction and MDS, etc., etc. SAMD9 is also associated with a variable range of MDS, physical abnormalities, immune deficiencies, etc. They're really becoming more and more. We need to learn about them and screen for them, especially for family counseling and monitoring of these patients. So what is the special workup we need for these patients? Hematological evaluation is important. It's important to know the disease phase, the clonal evolution for this disease, and the cancer screening. Evaluation also may be required for diseases that may involve the renal, cardiac, hepatic, and pulmonary, because some of the diseases may either affect these organs in terms of structure or function, or even development of fibrosis and progressive disease. Treatment history in these patients are important. Patients, for example, who are congenital neutropenia or Schwachman and GCSF, it may imply evolution of disease or development of molecular abnormality or dysplasia. Hormonal therapy, growth hormone, and androgens may also cause other complications. And steroids, and we know with the toxicity of steroids that we need to observe for. Allosensitization, especially in patients who are transfusion dependent, needs to be looked into. Patients who are requiring alternative donor, you need to screen for donor-specific antibodies against HLA. Patients also who are on transfusional dependent, they need to be monitored for iron overload, not only by ferritin, but by MRI T2 star of the liver and heart to look for iron, degree of iron load, and the need for proper chelation so that they can avoid unnecessarily toxicity of chemotherapy. This is in addition to the other routine workup that we do for the patients that includes these following investigation. So we'll start with Fanconi anemia, because it's probably a common hereditary bone marrow failure disease, and we know it is a bone marrow failure with progressive hematopoiesis failure, and it is known that they have excessive sensitivity to alkylating agent, that they have chromosomal breakage that is elicited by diepoxybutane or mitomycin C in lab that shows excessive chromosomal breakage, and that really is a diagnostic for this disease. They are also physically characterized by microcephaly, skin pigmentation, skeletal anomalies in the head and neck, in the face, ears, chin, eyes, and in the upper limbs by thumb abnormality and radius, genitourinary anomalies including ectopic or horseshoe kidney, hypospadias, etc. Short stature, mental retardation, vector association, especially with FANCD, 1 or BRCA2 genotype, hearing loss, and 30%, however, may not have physical anomalies. So don't ignore this fact that some of them will not manifest, abnormalities. We know that these patients may start to develop to show the hematological manifestation, although they are born with physical abnormalities, but the hematological manifestation may show a bit late, around the age of 4 to 7 years when they show the hematological evaluation. So you keep track of that. They are predisposed to cancer like leukemia, and the tissues of rapidly dividing nature like mouth, esophagus, and others. As you can see there, the development of MDS and AML is known. Therefore, before transplant, they need to be checked on an annual basis. And you can see here the squamous cell carcinoma that they are prone to. Fanconi anemia is caused by 22 genes abnormality involving the FANC constellation or complementation. As you can see, they're all responsible for DNA repair. So it's a really quite a big collection of genes. They are responsible for the genome instability and DNA repair. So they're all complementing each other, and they lead to chromosomal breakage ultimately. What are the indications for transplant if patient develops the hematological manifestation, and if they show any evidence of clonal evolution? And it's best to transplant these patients once they start receiving blood transfusion and before development of MDS or AML. And we know that these patients are extremely sensitive to chemotherapy because of their impaired ability to repair the DNS. This will lead to increased chemotherapy and radiation toxicity for these patients. Therefore, reduced intensity conditioning is used for these patients. And to give you the transplant experience, there's a large experience in Brazil with 425 transplants done in these patients using reduced intensity conditioning. This was done in different types of donors, mud mismatch related and haplo identical. The outcome showed that the non-radiation conditioning fares the best, and the low dose of cytoxan with fludarabine and ATG has the best outcome in these trials. As you can see in the graph here, the ATG had very good survival. However, combination of Cy/Flu and ATG with no TBI had the excellent survival, which goes from 80 to 95%. Match unrelated transplant can also be a good source of cells for these patients. At King Faisal Specialist Hospital here in Riyadh, our experience published by Dr. Ayas in 94 patients, all of them were match-related donor, using, again, reduced intensity in different eras here, started from 1995, we started with ATG, total abdominal irradiation, Cy 60 milligram with ATG or Cy, fludarabine, ATG, and incorporating TBI. And as you can see, the outcome is best in these patients who had radiation-free fludarabine-based regimen, and inferior in those who had radiation. In fact, some of those who had radiation developed secondary malignancies later on. So the overall survival is, as you can see, over 5 years of follow-up is still good in the whole group. However, it's best in the fludarabine-based regimen with survival 95%. 6 patients developed secondary malignancies, 3 squamous cell carcinoma, and 3 acute leukemias. This is the outcome of transplant done from alternative donor, either matched, unrelated, or mismatched, etc. Most of them utilized fludarabine and ATG, and most of them added TBI to the combination. And as you can see, the best experience was in these patients who had incorporated fludarabine and ATG with TBI, such as in our experience at King Faisal with excellent outcome, in fact. This is our experience with T-cell replete haploidentical. That means the product is not T-cell depleted, but it's complete T-cell graft. However, the cytoxan is given after the infusion of the graft, as shown here. As you can see, it's given after the graft. What we use is fludarabine, 30 milligram, and ATG 5 milligram, and TBI 200 milligram. This is the reduced dose of cytoxan to avoid toxicity or undue toxicity with 25 milligram in day 3 and 5. And the 5-year survival was almost 90%. 17 are alive and 2 died, 1 of severe graft-versus-host disease and 1 of leukemia relapse. What are the factors affecting the outcome in Fanconi anemia? Age and clonal evolution. The younger the patient, the better outcome. The older the patient, the highly likely chances that the patient is showing clonal evolution, as you can see here in the experience of 199 patients who had 46% had clonal evolution. The 3-4-year overall survival was 36%, and there is a high rate of transplant mortality in this group of patients. However, those who were transplanted after the year 2000, incorporating the fludarabine-based conditioning, have much better survival than the past. And still, the secondary malignancy remained a problem. And as you can see in this group. What about the patient who has still residual disease? We know that these patients cannot tolerate high-dose chemotherapy that we used for AML patients. So the sequential approach using sequential flag regimen, as you can see here, fared better survival. In the EBMT, 74 patients were done, 35 with MDS and 35 with leukemia. The 5-year-old survival was 42%, and the relapse was 40%. What are the complications after stem cell transplantation of Fanconi anemia? Of course, endocrine organ. We know that to start with, these patients have infertility, but other organs that are likely to be affected, like the growth hormone, thyroid dysfunction, hypogonadism, and pancreas. All males are infertile and low infertility in females. As I mentioned, the predisposition for cancer needs to be observed, and it can happen in these patients, especially those who had radiation therapy. So it is advised, to avoid radiation because it is associated with increased incidence together with severe graft-versus-host disease. As I mentioned earlier, lifelong surveillance of these patients is highly needed. So congenital dyskeratosis congenita is again another syndromic disease with cutaneous manifestation like leukoplakia or reticular hyperpigmentation, nail dystrophy, developmental delay, short stature, esophageal strictures, hyperhidrosis, and premalignant leukoplakia of the oral mucosa, and progressive pancytopenia. And there are 14 genes are responsible for the telomere maintenance. We know that this disease is well known for very short telomere because of the abnormality in any of these genes that are involved in the maintenance of the telomere. And it is also associated by hepatic and pulmonary fibrosis that exist and progress with years, with or without the transplant. However, after transplant, it's likely that the progression will be higher, especially if you use more intensive therapy. Neurological, ophthalmic, immune deficiencies are known association. The conservative therapy used to be androgens to improve the marrow function. However, stem cell transplantation is the only potential cure for dyskeratosis congenita. You need to monitor these patients and check them before transplant carefully for pulmonary fibrosis and hepatic fibrosis, AV malformation in the lung, liver, and GI. Complication, well-known neoplastic complication, increased malignancy, squamous cell carcinoma of skin, nasopharynx, esophagus, etc. Pulmonary complication, fibrosis, abnormality in the macrovascular system, and it's really becoming a challenge to transplant, especially if the developed, complication in that regards. It can be a leading cause of death. The bone marrow manifestation, the hematological manifestation, usually occur in the second decade of life, and this is the start of the problems and the evolution to cancer. And the aplastic anemia is usually diagnosed, or the hematologic manifestation starts probably at the age of 4, but it can present more or less later, around the age of 15. Natural history of the keratosis congenita, many times it is underdiagnosed or usually diagnosed late. 86% of the affected are male. As I mentioned, the mucocutaneous features may develop between the age of 5 and 15 years, and the peripheral cytopenias around the age of 10. Progressive fibrosis of the liver and lung, and the AV malformation is expected. The experience in stem cell transplantation of this keratosis congenita is not encouraging. The experience of EBMT in 94 patients, and these are data mostly after 2000 in 84%. All patients, of course, received direct because these patients do not tolerate regular doses of chemotherapy. Unfortunately, despite the engraftment, but as you follow these patients, the ongoing fibrosis and tissue damage continues, and some of the transplant actually enhance or may expedite the development of these complications. As you can see, as you follow these patients, they deteriorate and they die. The Brazilian experience is more or less similar to the European experience in 29 patients. As you can see, they have similar with overall survival of 62, but as you follow these patients, we expect them to do poorly. The poor outcome was noticed in the mismatched transplant. There are only 2 out of 8 who are alive. And post-transplant, the veno-occlusive disease of the liver, GI tract bleeding, and hepatopulmonary syndrome was the major cause of death. Out of 5, only 1 was alive. Pulmonary fibrosis occurred in 2. As you can see, they're quite common, and you need to look for them. And even post-transplant, as you follow them in the clinic, you need to have a good, follow-up of these patients, and may refer them to GI and pulmonology service. A good study, actually, it's a clinical trial, ongoing clinical trial by Sunit Agrawal, incorporating alemtuzumab, fludarabine, and bone marrow graft, was used in 20 patients, and so far that looks like the results are encouraging, and the curve is going quite satisfactory compared with the CIBMTR experience. So we're waiting for the final report to come in this regimen. We go now to Diamond-Blackfan anemia, and it's a disease that is characterized by macrocytic anemia, reticulocytopenia, and physical anomalies that really involve the face. As you can see, the eyes, the chin, their congenital anomalies, and increased predisposition to cancer. Mutation are recognized in 20 RPS genes in Diamond-Blackfan. The RPS 19 constitutes the larger portion of them. These patients typically present early in the first year of life, almost 90% of them, and you need to monitor these patients, and usually, as I mentioned earlier, they're managed with steroids and blood transfusion. And when the steroids become ineffective, or they develop toxicity to steroids, or the only way to manage them is through chronic transfusion, then you consider them for stem cell transplantation, especially if your steroid dose is still significant. You need to observe, like the other bone marrow failure, for aplasia, dysplasia, and malignancy. The outcome of stem cell transplantation is excellent, actually. In the German-French group, there are 70 patients, mostly the pediatric age group, a median of 5 years. The survival was excellent using matched sibling donor or matched unrelated. It's almost 100%. Similar thing was seen in Brazilian group treated 44. Mind you, here they used combination of patients with unrelated cord transplant, MUD mismatch, and haplo. So they have some patients who did not do well. But invariably, patients who are treated with busulfan, fludarabine, or busulfan, trisulfan, fludarabine, ATG combination, they have the best outcome, especially those with MRD and MUD. We go to severe congenital neutropenia, and we know that the neutropenia, congenital neutropenia, is a congenital disease known to have recurrent infections and severe neutropenia with neutrophils less than 500 or less than 200. And, they have characteristic abnormality in the bone marrow with maturation arrest. There are different genes described in this category, especially Elaine mutation that encompasses the bulk of the gene abnormality and autosomal dominant. However, other genes were described. HAX1, we've seen it in several patients in our hospital, and it's autosomal recessive, and they have progressive neurological changes and developmental delay. Others are associated with cardiac defects and thrombocytopenia, etc. As you can see, the distribution of the genetic abnormalities here. As I mentioned before, it's characterized by recurrent infection. Patients will have really failure to thrive, recurrent, diarrhea and deep-seated infections, and they have predisposition to hematological malignancy. The indication for transplant for severe congenital neutropenia, lack of response to high doses of GCSF. Usually, the average doses is 5 mics per kilo per day, is up to 10 mics per day, provided you have adequate, response is fine. But you reach more than 20 or 50 with the presence of clonal evolution or mutation. That is an indication to move to transplant. Outcome is best in young children, MUD or match unrelated, and you need myeloablative conditioning. As you can see, the outcome has been excellent. The mismatch, however, did poorly. Schwachman-Diamond is the other side of congenital neutropenia, characterized by progressive bone marrow failure. They have exocrine pancreatic dysfunction, malabsorption, skeletal abnormalities, and failure to thrive. They are highly predisposed to hematological malignancies, and these patients, if they present with severe pancytopenia or neutropenia, they are candidate for transplant. Definitely when they have clonal evolution, but they are also, it's up to 25% they may develop it. The outcome after myeloablative conditioning, 70% 5-year overall survival. However, if they develop MDS or AML, the outcome is poor, as you can see in this curve. Development of myeloid malignancy, in most of the severe congenital neutropenia, you expect that these patients may develop, malignancy, especially monosomy 7, trisomy 13. Schwachman-Diamond syndrome, similarly high rate of, transformation to AML, and the majority may have the TP53 mutation and may have monosomy 7. These are the outcome and the EBMT in patients with severe congenital neutropenia. The patients transplanted without malignancy, the outcome is 87 and 78 here. Again, it's relatively good when they in the early transformation to malignancy. However, in the Schwachman-Diamond syndrome, 72 and 71, and poor outcome once they transfer to malignancy. And before I end, this is the outcome in rare, diseases such as megakaryocytic thrombocytopenia. As you can see, they're using myeloablative conditioning, MUD or match-related donor. The outcome is 76%. The GATA2, and this is again, critical and important, transcription factor for the maintenance in immune and hematological tissue, and the outcome of it is 75%. MICOM is a new syndrome, is characterized by, again, bone marrow failure, thrombocytopenia, cardiac, renal deafness, and skeleton, upper limbs abnormality, and the outcome here is actually 3 patients died, so it's not, the outcome has not been encouraging. In SAMD9 and SAMD-L, again, these patients manifest with myelodysplasia and bone marrow failure and Mirage syndrome, which is a constellation of physical abnormalities. There are here 12 patients which are transplanted, most of them myeloablative syndrome. And mind you, these diseases are new and they're being explored. What is the best conditioning? What is the natural history of these diseases? And what is the outcome of these patients? And it looks like there are 10 patients alive after myeloablative conditioning in these diseases. So in summary, the special consideration for transplant in inherited bone marrow failure, you need to early recognize these patients, and you need to do accurate diagnosis. Molecular diagnosis are needed, and especially if you have to take special tissues to make the diagnosis, because invariably in the pediatric age group, many of the new described genetic mutation are missed because of lack of the proper tissue diagnosis. This is done in the patient as well in the potential donors. Proper screening, you have to monitor these patients, study the bone marrow and blood carefully for mutation, dysplasia, and cytogenetic abnormalities and moleculars. The best source of stem cell is the bone marrow. The best donor is from HLA match sibling or related donor. Alternative donor, match unrelated donor, haploidentical, can be offered to these patients. The use of alpha beta T cell depletion marrow or T cell repeat haplo transplant may offer good alternative to match related donor. Fludarabine based conditioning is promising, is actually showed significant improvement in the outcome compared to the past, and reduced the transplant related toxicities from the previous conditioning chemotherapies. Inherited bone marrow failure diseases are still underdiagnosed. There is a need to improve the diagnostic methods and tissue sampling. There's a need to understand the disease behavior as well. Lifelong follow-up in these patients is needed, and proper screening for cancer and organ dysfunction, especially in patients that are like Fanconi or dyskeratosis ingenita, to monitor for liver, lung, and GI is very important. And with that, I'll conclude my talk. Thank you.
Thank you, Dr. Jeffrey, for this excellent talk. And we now move to the next speaker and next talk. Dr. Turki is a consultant of genomics and bioinformatics at King Saud University. Dr. Turki currently leads the molecular genetic lab at King University and Anwar Lab. He leads multiple national screening program for genomics profiling of multiple cancer across the country. And without further ado, Dr. Turki is going to present us germline mutations versus somatic mutations. Dr. Saeed, the mic is yours.
Thank you very much, Dr. Al-Ahmari. Assalamu alaikum wa rahmatullah. Good evening, ladies and gentlemen. It's my great pleasure to be here today, and I would like to thank the organizer committee and Dr. Al-Isa for their kind invitation. Dr. Ahmari, can you confirm my slides are working?
Yes.
Perfect, thank you. So the elegant talk by Dr. Jibri is a nice segue to what I will talk about, which basically how from the lab side we report deleterious germline variants in hematological disorders, some thoughts on it, what's the process look like, some caveats to share with you this very important component that is growing in the medical practice over the last few years. So just to be on the same page, this is 101 genetics, somatic versus germline. This talk is all about the inherited mutations from the parents that get passed to the germline cells, the gametes, sperms, ova, to the zygote, and then it will be copied in all of the cells in the embryo, and it will increase the predisposition to cancer, and the same mutation can pass to next generation. Unlike what we are all used to in hematological malignancies, the somatic mutation, which basically is not passed from upstream from the parents, but in fact is affecting a few cells in the body, usually caused by external factors in most cases, and it does not, they usually don't pass or transmit it to the next generation. So my talk is divided in three parts. Very quickly, we'll talk about the landscape of germline mutation and hematological disorders. Then what are the guidelines that is we use in reporting the pathogenicity of some of these mutations, especially those never seen before in the general population, and how can we be sure that we are classifying them in a systematic way. And finally, we'll see from the lab point of view, how does that fit into the workflow. So one of the largest studies that done in this area is this study from St. Jude Children's Research, a group in 2015, where they basically sequenced more than 1,000 patients younger than 20 years old. They used the combination of whole exome and or whole genome sequencing, and they focused on 500 genes related to cancer, with more than 60 genes of them being associated with autosomal dominant cancer predisposition syndromes. And they found that 1 in 12, or 8.5% of that cohort actually had a germline mutation in one of those gene of interest. When we look at the breakdown of this mutation, you will find that, and this is both solid tumors and hematological, leukemias and lymphoma represents almost 33% of the cohorts. So it's a big chunk of cancers that with the germline component. And if we say, let's zoom in a little bit, forget about solid tumors, let's focus on hematological malignancies. This is another study that showed when those patients, 67 of them, referred to hereditary hematological malignancy clinic, they found in 1 in 6 of them carry a germline predisposition to malignancies. So it is a big part. Germline is a big part, from 1 in 12 to 1 in 6. There is a growing evidence that it is more than what we think. Individually, they are rare, but together it's quite common. So when do we suspect a germline components in our patients? Of course, through the personal history and family history, we can suspect if there is multiple affected, multiple cancers. But I have to say that family history is not always positive. In fact, less than 45% of the patient will have a positive history. And this is especially true when we are dealing with autosomal recessive disorders, where parents will be normal, but they are silent carriers. And when we are talking about the physical exam, this table will show you the wide spectrum of presentations associated with different genes. So in the left axis, the clinical features range between hematological findings to others in renal, cardiac, and other organs. And if we pick Elaine gene, for example, it usually presents with neutropenia and skin manifestation and affecting the growth, On the other hand, GATA2 is beside the hematological, it comes with immunodeficiency. But as you can see, the presentation can vary a lot between the genes. And if we are trying to see what are the clusters of these syndromes that Dr. Al-Jifri mentioned, some of them with the bone marrow failure, MDS, AML, and ALL, you will see, yes, bone marrow is associated with few of them, as well as lymphoma, but MDS and AML is usually appears in many of these syndromes. And if we want to discuss the mode of inheritance, autosomal dominance is there, X-linked is there, autosomal recessive is there. So it's a quite complex spectrum that could surprise us from different angles when we are dealing with the patient. So the question now becomes, if we are presented with a lot of genes, different presentation, what is the methods in the lab that we can use to test for germline mutation? Knowing that we are, we have more than 3 billion base pairs in the human genome. So do we do whole genome sequencing, or we focus on specific genes? And what makes it a little bit more complicated is we are dealing with different biomarkers at the DNA level, from point mutations to insertion deletions, large copy number variants, and then the structure variants with the gene fusion and translocation. And all of these require different methods, and not all methods are suitable for detecting these biomarkers. So in this slide, we are listing as a big, the large picture, the big picture, the different methods, that we use in the lab to detect some or all of these mutation. One of the most commonly wide used is the real-time PCR or the PCR-based assays, and it can detect point mutation and insertions and fusions, but it has to be well known. So it's not good when we are dealing with germline mutation because it's not a hotspot mutation. We don't know what we are dealing with. So PCR methods usually is not advisable in this scenario. FISH, on the other hand, is great for copy number variants and fusion, but it's not good for the smaller mutations or biomarkers. And if we are dealing with arrays, then copy number variants is probably the only thing that it can detect. So the golden standard usually is the capillary sequencing, which is the Sanger sequencing. It's an old method from 1970s, fantastic method, but it is very limited on the number of targets that we can use for. So naturally, in the last 5 years or so, next generation sequencing, which has the ability to detect theoretically all of these biomarkers, is usually the gold standard and the way to go, especially when we are dealing with multiple targets. As you saw with the Fanconi syndrome, 22 genes. If we are doing it with Sanger sequencing, it will cost probably 20,000-30,000 riyal, while with the NGS, it's a fraction of that, and it will cover most of the genes that we are interested in. So what is the tissue type that is suitable to confirm germline mutation? The blood, of course, is not a good source to confirm germline, given that the tumor cells is there, and we cannot distinguish germline from somatic from the blood. Buccal swab is widely used, but again, WBC's white blood cells can contaminate the buccal swabs, so it's not advisable, but can be used. Hair follicle is a much better sample, but it has the problem of being so small that it's required a very specialized lab to deal with a tiny number of cells where we can detect the germline mutation. So the most important tissue sample is the bunch biopsy or the skin biopsy, where basically we can use it, although it's a little bit invasive, to confirm the germline mutations. So the moment we are dealing with a mutation, a germline mutation, and we want to classify it and understand its pathogenicity, in order to make all the labs produce systematic, standardized way, 2015, there was a guidelines released by the College of American Pathologists and the Association for Molecular Pathology, where they listed a lot of protocol basically on how to approach it. I'm not going in any details of this. It's very extensive. I'm just showing a few things that we deal with. For example, they classify the evidence that support any mutation based on multiple axioms. In this case, if it is a truncating mutation, usually it's given a very strong evidence, but it's not alone. So we usually deal with multiple line of evidence. You see here each row represents one. For example, how frequent is this mutation in population? What does the computational and predictive data say about it? And in the third row, functional data that supports the pathogenicity. And accordingly, we weigh those evidence and give it as a benign or pathogenic. The right side, the pathogenicity can range from supporting, moderate, to strong, and very strong. And just to give you one example of how we use population data to decide if this mutation is worth investigating as a pathogenic or not, we use multiple databases. One of the most commonly used one and the largest actually available is a free resource called Nomad. It's available online at the URL at the bottom. And it hosts more than 140,000 individual using whole exome or whole genome. So it's an unbelievably huge database from different populations, actually. And you see in this figure, how are those individuals clustered together based on their origin, from South Asians to Southern European, Swedish, Finnish, etc. And the word of caution here is Middle Eastern population is not well represented in this database, although there is some efforts into adding some of the population, especially from the Gulf countries where they already have sequenced thousands of patients, into these publicly available resources. And if we are looking in one of those genes here, depicting the MPL gene, you see these curves that represents how well is the coverage at every exon. And if we are zooming in any of those exons, we will see a list of mutation. Each row represents one mutation with the classification that has been published before. And if we click on any of those mutation, we will have a breakdown and a zoom in and how common is that variance in different populations. Here is the allele counts. Here are the number of homozygous. So together, this paints an idea of a very rare mutation that does not appear in a lot of individual. So the rarer the mutation is, the more confident we are that it is actually lycopathogenic or pathogenic. And that's not the only evidence. As I mentioned, we use other resources, but it's a quite extensive process to evaluate every variance, making sure that it can explain the phenotype in the patient, because there's so many decisions that will be based on this. For one, it will provide diagnosis, to surveillance in the patients and the family, and later it will be very important when the time comes for donors to make sure that they don't carry the same mutation as the patients. So the last part is the workflow in the lab. And usually it's take place after doing the initial workup, from morphological assessments to the flow and immunophenotyping, cytogenetics, and FISH, and the molecular studies. So if all of this is done, and this is one way of catching some of those patients, and assuming that we are doing a large panel for the hematological malignancies, some of those panels may have or include predisposition genes. And if we find a mutation there with a variant allele frequency of 30% or more, then this may indicate a germline mutation, and it warrants going through to get a skin biopsy. And from that, we can confirm it using a comprehensive germline testing. I need to focus on the VAF, the variant allele frequency, and explain what does that mean in this context. So there is a population frequency, and we assume it's very rare. But when we are sequencing the patient's DNA, we want to see a mutation with a higher frequency in his own DNA molecules. And if we are using next generation sequencing, it will give us tons, millions of short DNA segments that's actually required to be mapped to the genome. So in this picture, you see 5 random DNA fragments from that patient. And usually the first step is to take every read and try to map it to the genome to figure out where does it fit. We do that automatically in the pipeline for all of those reads. Once it's aligned, the next step is to start screening all those regions vertically, looking for difference between reference genome and those patient DNA segments. And the moment we detect a difference, we pick that as a potential mutation. And then we measure how many evidence supporting the reference genome versus the alternative allele. In this case, for example, let's assume there is 100 reads, NGS reads, covering that region. If the normal allele is supported by 55, then the allele frequency here is 55% and 45% for the variant allele. The reason I'm mentioning this is for somatic mutation, usually it's much lower, 20%, less than 30%. Anything above that is potentially a germline mutation that require a skin biopsy to confirm it. And if we are not dealing with the patients through this approach, the other is with the family history or the clinical history of multiple cancers or young age than the usual, or a strong family history, then we can go directly into the comprehensive germline testing. And the moment we detect a deleterious or confirm it in the patients, then this warrants a follow-up with the surveillance, offering counseling for the patient and the family, and doing a cascade or segregation study in the family members, and assess the related donors for the familial variants. And so in summary, we discussed when to suspect the germline components in hematological malignancies. It's more common than we think, up to 1 in 6. Family history is not always present. It's usually in less than 45%. We discuss NGS as the most important method to use in this situation, mostly because of the large number of genes to be investigated. Skin biopsy, of course, is the gold standard here. And the AMP and CAP guidelines is what we use to systematically interpret and classify variants of unknown significance. And with that, I reached the end of my talk. Thank you very much for listening.
Great. Thank you, Dr. Turki, for this outstanding talk. And then we will be moving now to the last talk in this session. It gives me a great pleasure to introduce Prof. Carl Allen. Prof. Allen is a professor of pediatrics at Baylor College of Medicine. He is also a co-director of the Lymphoma and Histiocytosis Program and Director of Research of Global Hope at Texas Children's Hospital Cancer Center. His focus of clinical and translational research efforts to develop and test therapeutic strategies for children with histiocytic disorders and lymphoma. He is a BI and co-BI for many clinical trials. He developed the first LCH clinical trial within Children's Oncology Group. Dr. Allen is the co-founder for and the co-BI of North American Consortium of Histiocytosis Research. He received many honors and awards, and he published more than 100 papers in peer-reviewed journals. Without further ado, Dr. Allen is going to talk today to us about Langerhans histiocytosis in children. Dr. Allen, the mic is yours.
Thank you very much. I just want to be sure you can hear me okay?
Yes.
Okay, perfect. Well, it's certainly an honor to join this conference, and I thought the last 2 talks were really exceptional, and I think set of framework, what we'll be focusing on today is really looking at how Langerhans cell histiocytosis, or LCH, is now recognized as a myeloid disorder characterized by recurrent somatic mutations. So I think we have a common theme here. So we'll talk a little bit about the historic background of LCH, then some new concepts of LCH, because it's really changed over the last decade. And then most importantly, look at opportunities to improve outcomes for our patients. So for the previous century, from the 1900s, really LCH was characterized through several case reports and case series based on these really heterogeneous presentations of children and even adults who had these characteristic lesions, including bone lesions, some lung lesions you can see here, skin rashes that can be confused with other more common pediatric conditions. Here's a patient who had really multifocal bony destruction of his skull. We can also get orbital lesions. The pituitary is quite commonly impacted, where patients can present with diabetes insipidus and loss of pituitary function. And then progressive neurodegeneration is also something we'll talk about. That's one of the, I think, still major problems in LCH. Sorry, next slide. So as people were starting to look at these cases and trying to characterize them, initially they were described as these distinct categories. This case would be described as a single bone lesion or just an eosinophilic granuloma. Here's a patient with pretty extensive disease, but without disease in the liver, spleen, or bone marrow. This would be considered multifocal low-risk disease. So this might be considered quite morbid, but typically isn't lethal, where this patient would have high-risk disease like the Letter or Seaweed condition that's been described in the literature, where there's bone lesions, but also spleen, liver, and bone marrow. So this patient might present like they have leukemia, for example. So the Histiocyte Society was a group of physicians and scientists with interest in these disorders, and as they started to share their experiences, it became clear that there were really two types of LCH. Again, one's where you have liver, spleen, and bone marrow involvement, these patients with the highest risk of death. And these Kaplan-Meier curves really associate with the responses at 6 weeks. If there's no response at 6 weeks of therapy, if there's a moderate response, or if there's a good response. And this was based on an LCH2 clinical trial. By comparison, for low-risk patients, even though they might have very extensive disease, as described in the previous slide, it typically wasn't lethal. And whether a patient is characterized as high risk or low risk, I think those of you in the audience who take care of these patients recognize the major challenge of frequent recurrence. So about half the patients will relapse despite frontline therapy. So historically, again, around the 1950s, these different types of patients were characterized as having, Letter Seaweed disease or Hashimoto-Pritzker disease or eosinophilic granuloma. Despite these various categories, several pathologists noticed that they all looked the same under the microscope and proposed a unifying hypothesis saying this group of diseases should be called histiocytosis X, where X means we don't really understand the cell of origin at this point, but this is a common condition. And in the 1960s and 1970s, with the advent of electron microscopy, as different tissues were being analyzed, this tennis racket-shaped organelle called the Burbeck granule was identified. And the only other tissue where the Burbeck granule had been identified previously was in the epidermal Langerhans cells of skin. And so a hypothesis was made that this disease comes from epidermal Langerhans cells. And since then, the disease has been characterized as Langerhans cell histiocytosis. So just for histology, this is a typical sheet of histiocytes intermixed with lymphocytes. And this coffee bean shaped nucleus is really quite characteristic. And these cells will stain positive for CD207 and CD1A, less so for macrophage markers of FAS and factor 13A that characterize juvenile xanthogranuloma and some other related conditions. And as was mentioned before, somatic mutation rate or very little frequency is quite important. Notably, the median number of pathologic cells in LCH is around 7%. So sometimes if you do Sanger sequencing or less sensitive sequencing, you can miss cases in LCH. So just to talk about ontogeny for a moment, let's think about epidermal Langerhans cells. So if LCH really comes from epidermal Langerhans cells, these would then arise from the fetal yolk sac precursors that seed our skin during early development. So what's thought is that there's some kind of pathologic activation or some kind of transformation of these epidermal Langerhans cells that go on to create LCH. And that was really the model for the early 2000s. All right, a lot's happened in the last decade. So let's discuss that and how it impacts LCH. So when I joined Texas Children's Hospital as a fellow, I started working with Ken McLean, who had quite a large clinic of LCH patients. And we started keeping biopsy specimens viably preserved from these cases and started to be able to do flow cytometry to differentiate the CD207, CD1A positive cells here. And you can see in this case, 32% of the cells are these pathologic Langerhans cells. And we compared gene expression of those cells against epidermal Langerhans cells. And what we found was really quite surprising. We saw all these markers that you might see in AML that characterize the epidermal Langerhans, or that characterize the LCH lesion CD207 positive cells as perhaps less mature than epidermal Langerhans cells. And when we think about the previous model of LCH arising from these cells, it didn't make a lot of sense. So at the same time, several different immunologists and dendritic cell biologists were realizing that you could really get these epidermal Langerhans cells or CD207 positive cells from multiple different sources. So yes, they come from the fetal yolk sac during development, but during inflammation, as these get mobilized into the lymph nodes by upregulation of CCR7, for example, they're replaced by monocytes that are indistinguishable from innate epidermal Langerhans cells. Similarly, there's these cells floating around the dermis called dermal dendritic cells that also express CD207. So this expression of CD207 is really no longer a specific feature of LCH, or epidermal Langerhans cells, rather. Another major discovery is that Barrett Rollins' lab at Boston, at Dana-Farber Cancer Center in Boston. He and his group discovered recurrent mutations. 57% of LCH lesions had the BRAF V600E mutation. And in every case they looked at, the MAP kinase pathway was activated. In their series, they didn't find a significant clinical correlation between genotype and this mutation. And just to kind of review very quickly, every cell has this sort of antenna that detects what's going on in the environment. It transduces signals through RAS, RAF, MEK, and ERK when the cell is behaving properly. And that regulates some kind of signal transduction or transcriptional regulation that then follows. In the case of BRAF V600E, this is a very strong signal that's always on. So it's like the light switch is always on with no opposed signal. And this is really what's considered responsible for a lot of pathologic activation, depending on the cellular context. So we had 100 LCH lesions frozen away when Dr. Rollins made his discovery. And so we asked the question, do we notice the same thing? So we have a highly sensitive BRAF V600E qPCR. And when we applied this to our series, we found 63% of the cases, in fact, were BRAF V600E positive as well. We didn't detect a difference between high risk and low risk cases, although the French group and others have noted a higher frequency of V600E in some high risk cohorts. But there's also no difference in age, gender, et cetera. But what we did find was a significant difference in the aggressiveness of the disease. We found that V600E positive mutations were twice as likely to relapse after initial therapy. So after we noticed that the LCH lesions carry this BRAF V600E mutation, we asked the question, where are these cells coming from? When we look in the blood or bone marrow of these patients, do we identify precursor cells? And initially, the results were quite confusing because in some cases it was positive, in other cases it was negative. But as we arranged them according to the risk category, we found that in every single case of high-risk LCH, we could detect peripheral blood cells, very, very small percentage. You can see here down to 0.02%. That carry the BRAF V600 mutation less reliably in the non-risk multi-site disease, and in this series, at least, in no cases of non-risk single lesion disease. So when we asked the question, where do these cells come from, we looked in the peripheral blood, and we found that the highest percentage were in the CD11C myeloid precursors as well as the CD14 monocytes. This really localized these positive cells to myeloid precursors. So working with Miriam Murad's group at Mount Sinai, we then asked the question, well, can we recreate this phenotype in mice? And the first thing we did was enforce expression of BRAF V600E and CD207 positive cells. So these mice are born normally, the cells develop, and only in cells that express CD207 is BRAF V600E expressed. And these mice weren't particularly sick. They didn't really get a very severe phenotype. They got some really minor LCH lesions, but it wasn't a very dramatic phenotype. However, when we based on our human results, pulled back and expressed CD11C positive cells to enforce expression of BRAF V600E. These mice developed really explosive disease that looked a lot like high-risk LCH, including CD207 positive cells. So this led us to hypothesize that the extent of disease in LCH isn't really due to differences in the number of mutations or even the types of mutations, but where does the cell first go bad? So if you have the mutation in an LCH precursor in the bone marrow, you're able to develop high-risk multisystem disease. If it's a more differentiated cell, you can get low-risk multisystem disease. Or if it's really at a highly differentiated precursor cell, you can end up with low-risk single lesion disease. So then we asked the next question: if we have BRAF V600E, are there other cells that are there other mutations that can drive LCH? And so, working with Will Parsons and the Human Genome Sequencing Center, we arranged LCH sort of in the context of a number of somatic mutations. And you can see here, adult cancers all have more mutations than pediatric cancers, but even among pediatric cancers, there were very, very few hits, only 1 or 2 mutations per cell within the LCH series. And when we looked at what those mutations were, it was quite telling. MAP2K1 was the most common alternative mutation, and that encodes MEK. So what you're seeing here is mutually exclusive mutations in MAP kinase pathway. And so now we've sequenced about 100 or so cases, and we've been able to find MAP kinase pathway mutations in every single case, including alternative mutations in BRAF, fusions in indels, leaving only about 11% of the cases that we haven't yet solved. I want to take a second to talk about the central nervous system disease, because I think this really informs the model of LCH. As I mentioned previously, LCH-associated neurodegeneration is a major problem that we still have yet to solve in LCH. About 5% of patients will develop this neurodegeneration 5 or 10 years, in some cases after their initial disease. And it's not been clear what this is caused by. There's been early speculation this is a paraneoplastic phenomenon or autoimmune phenomenon. In an early series of patients, Ken McLean tried treating them with LCH-directed therapy with cytarabine. And this is an example of a boy who actually had pretty good improvement in his handwriting, reflecting better cerebellar function when he was treated with LCH-directed chemotherapy. While early studies showed that that these neurodegenerative lesions weren't characterized by CD207 positive cells, we took a look at a couple new biopsies that we had access to. And you can see here in a case where neurodegeneration showed up very, very early in the course of disease along with systemic lesions, you can see this whisper of CD207 positive cells. Where in this case of more long-standing neurodegeneration, there aren't any CD207 positive cells, but there is really heavy expression of BRAF V600E identified by VE1 in both of these cases. We had another patient who tragically died of neurodegeneration, and we were able to perform genotyping on different sections of his brain. And you can see that his brainstem really was composed of 13% of the cells were BRAF V600E positive, a little bit less in the pons and cerebellum, and much, much less in the temporal lobe. And this really correlates with the radiographic findings, where you have much more disease in the brainstem and cerebellum than in the frontal cortex. When we take a closer look at this patient, you can really see sort of this pattern where you have VE1 positive cells or BRAF V600E positive cells around the blood vessel. And this is perhaps informing a model where these LCH precursor cells can migrate to the brain from circulation. So if LCH is caused by BRAF V600E activation in microglia-like cells within the brain, we asked the question if MAP kinase blockade could be effective therapy. So we treated 4 patients with vemurafenib. And interestingly, these are patients who have been heavily pretreated with other types of therapies without a lot of benefit. But in 3 out of the 4 cases, we had a pretty remarkable clinical and radiologic response to vemurafenib. This one patient who didn't really respond has had long-standing disease for 10 years. You can see his cerebellum is really quite atrophied. And so the potential for improvement is not really clear in that patient. And so now we have this model where perhaps neurodegeneration can be explained by persistence of a precursor cell that has the capacity to migrate to the brain and cause neurodegeneration. All right, so now that we have this model of LCH that's a bit refreshed from the last century, where LCH is really this myeloid inflammatory neoplastic disease caused by somatic mutations in MAP kinase pathway genes, how do we do a better job at treating these patients? If you look at the chemotherapy-based strategies in LCH1, 2, and 3, you can see the steady improvement over the last several decades. LCH3 patients being treated with vinblastine and prednisone. But if you ask the question, how many of these patients are cured with this approach, it's fewer than 41%, which is not an optimal outcome. So there's some efforts underway to try to improve this with other chemotherapy strategies. The Histocyte Society is currently asking the question in LCH4, the difference between 1 and 2 years of therapy, to see if that creates improvement. Based on some observations that some nucleoside analogs, including cladribine, and cytarabine, and clofarabine, perhaps can have some effect on LCH. But the dose really matters. If you underdose, as in this study with 2-CDA, only 3% of the patients had progression-free survival at 3 months. But if you use extremely high dose, 2-CDA and Ara-C, similar to treating AML, 100% of the patients who survived the therapy were cured, but 30% of the patients died from treatment-related mortality. So we're really looking at cytarabine and clofarabine as possible strategies for outpatient chemotherapy that can cure these patients. We're also asking a question in an institutional series, how does frontline cytarabine compare to vinblastine and prednisone? So these are all clinical studies that are underway, but what makes a lot of sense to say, well, okay, well, if we identify these MAP kinase pathway mutations, what happens if we block them? I mean, certainly that makes a lot more sense as a rational cure. And some adult studies early on gave us a glimpse of what the potential is. Initially, the MSK group, Memorial Sloan Kettering group, did a phase 2 basket study where they included LCH and perhaps had a slightly disappointing response rate of 43% in that series. But they used RECIST criteria. But if you go on to use metabolic responses by PERSIST, a follow-up series had 100% response rates. Interestingly, however, if you stop therapy, nearly all patients relapse. This was a study by Julien Hiroche in the French group. So patients who have been treated for 2 years with MAP kinase inhibition, therapy was stopped, and they almost universally developed recurrent disease within 6 months. So this suggests there's not a durable response in these patients. I'm sorry, I'm not sure what happened to the imaging here. Okay, that's better. As a follow-up study, a question is, okay, well, BRAF V600E inhibitor only works if you have BRAF V600E, but if you just use MEK inhibition for all patients, what happens? Eli Diamond led the study from MSK and found some really excellent results in adults who had an extraordinarily high response rate. Similarly, the French group led by Jean Donadieu tried using vemurafenib right after failure of vinblastine and prednisone in high-risk patients and had excellent responses. But again, in his series, as soon as therapy was stopped, there was a very sharp decline in durability of response. So we're now studying through the NACHO consortium the impact of blocking MEK activation with cobimetinib in a pediatric cohort, LCH neurodegeneration, the rare conditions such as juvenile xanthogranuloma and Rosen-Dorfman disease, as well as adult histiocytoses. And hopefully we'll have some data to report soon. So do we say, okay, well, we block hyperactive RAS, is this mission accomplished? I don't think so. I think there's still some questions that we need to address to be able to get a more durable response. And we have, just very briefly, I'll go over some new, relatively new biology findings that might inform this. One thing that was noted in LCH that was a bit surprising that we and others have looked at is when you look at the rate of proliferation in these cells, it's not particularly high. So Ki67, a marker of proliferation, is in green here, and you can see it's really no different than in epidermal Langerhans cells. So if these cells aren't proliferating, what's happening? And to cut to the chase, what's really going on here is these cells are accumulating at sites of disease. As an experiment in those LCH mice I described, when we paint their skin with fluorescent tracer, they accumulate within the lesions and they're unable to traffic to the lymph nodes, where normal animals, you can see here, you have fluorescent positivity in the lymph nodes, but not in the LCH lesions, or not in the LCH mice. And what we discovered was the reason for this is lack of upregulation of CCR7 that's blocked by MAP kinase signaling in LCH. When we add MEK inhibitor, this is reversed, and these cells are allowed to drain from the LCH lesion sites and go into the lymph node. These cells are also resistant to cell death. They overexpress BCL-XL. And so, one idea is when we add MEK inhibitor to these BRAF V600E positive lesion cells, this is a human LCH lesion, we really increase the sensitivity to cell death. So is this kind of like we see in the B cells and T cells in ALPS where they accumulate and they just don't die? I think that's a myeloid equivalent here in LCH. Another thing we recently published with Mira Murad's group is identification of the senescent signature. So these cells are sort of frozen, they hunker down, they create an inflammatory response, but they just don't die. And so trying to think about how to uncouple that senescent mechanism from MAP kinase signaling is another strategy that we're looking at right now. And one way to do that is to target BCL-XL. And you can see here the mice had an excellent response to this BCL-XL inhibitor. So this may be another approach we can take advantage of. Finally, I mentioned that there's this inflammatory microenvironment in LCH. These cells are exhausted, they're angry. I don't think they're CD8 targeting T cells, but they're really causing a lot of the pathology. And at least in a mouse model, what we demonstrated was that blocking with MEK inhibitor as well as a checkpoint inhibitor, PD-1, was quite synergistic. And this is something that I think that needs to be explored in clinical trials. So hopefully what I've told you in the last half hour or so is that LCH started off as this constellation of clinical symptoms that we didn't quite understand. When you look under the microscope, it all looks the same. So this disease was called histiocytosis X. Once CD207 was appreciated, we then called it LCH because we thought these came from epidermal Langerhans cells. And now we recognize that's probably not the case, and thinking, well, is this really better histiocytosis X, Y, or Z, depending on what your personal mutation is and what cell it arises in. This is really, I think, a model for a personalized approach to this condition. And so for some therapeutic opportunities, I think there's a lot of potential targets. In addition to blocking MAP kinase signaling, can we block differentiation, migration, apoptosis inhibition, as well as inflammation to get better outcomes for our patients? And so I know we're running out of time, so I'll just highlight my team led by Ken McLean and Rikia Chakraborty. A great collaboration with Mira Murad, as well as others around the world, have led to some of these discoveries. And I look forward to any questions.
Hey, thank you so much, Prof. Allen. Great talk. So to be fair, let's start with the last. So I will start first question for Dr. Allen. So we have potential targeted therapy for LCH, MEK inhibitor and BRAF inhibitors. So can we extrapolate from what we are doing now in leukemia and other malignancies in bringing those targeted therapy to the backbone and fit it somewhere in the standard chemotherapy for LCH? Do you think that will improve the outcome for high-risk patients? And the other question also, have we tried using a combination of MEK as well as BRAF inhibitors clinically in clinical trial?
So those are excellent questions, and I think it's really what the field is wrestling with right now is how best to use. These agents have extraordinary response rates, but it's not a durable response. There's some toxicity associated with being on these therapies, and so some in the field are putting their patients on these inhibitors and just keeping them on them kind of ongoing. I think your question about how to incorporate them into other strategies is an excellent one. I think now that we're starting to get some outcome data from LCH as well as some safety data from other pediatric indications, there'll be a move to move these inhibitors earlier to get a better response, but then try to figure out how can we cure these patients either along with the inhibitors or following inhibitor therapy. So that's one of the things we're trying to incorporate into the Nacho cobimetinib trial. And then also LCH has just been taken on by the Children's Oncology Group. It's one of the diseases that they recognize. And so hopefully we'll have an LCH trial coming out in Children's Oncology Group. And clinical trials are clearly the place we have to ask these questions. But like a lot of other kind of rare diseases, now we have this issue of so many different therapies to try. How do you prioritize those, which agents within classes, et cetera, is something that I think we just need to be strategic about. But yes, I think to your point that this definitely is something that needs to happen, is to figure out how to best use these inhibitors and in combination with what other therapies. There hasn't been a lot of use of them combined. And I think one of the issues around LCH that's different than other conditions is that, again, these mutations are one or two mutations that drive the disease. When you look at melanoma, colon cancer, other BRAF V600E diseases, that's one mutation of hundreds of mutations. And so I think there's probably a different risk profile as well as a different efficacy profile for what I would say one or minor mutation disease versus heavy mutation disease. And I think it probably most analogous to LCH would be looking at like low-grade glioma or neurofibromatosis, for examples, rather than looking at much more highly mutated diseases.
Okay, thank you. Another question in the same line. Do you think there is a place for targeted therapy in high-risk LCH patient who underwent stem cell transplantation, post-stem cell transplantation in the future, do you think?
So if there, hopefully no LCH patients will have to get transplanted in the future. I think that LCH should be controllable in almost all cases. Unless, I mean, there are some cases where it looks like LCH, but it's really a much more complex biology, like histiocytic sarcoma or LCH that arises in the setting of leukemia. I think that's really more of a biophenotypic leukemia. And so those cases may have to go to transplant. In those cases, I think blockade may be helpful, but hopefully once someone's transplanted, they don't no longer have the clone. But I think in this modern era of MAP kinase inhibitors, we should not have to transplant patients with LCH.
I got a question here in the chat box. The role of PET scan in monitoring remission in LCH. That's
an excellent question. I think that we're learning with LCH, like other lymphomas, that PET scan is critical, especially when we're using the MAP kinase inhibitors, because disease resolution can take a while, especially with these bone lesions, right, where you have tissue destruction. It's hard to kind of tell the difference between the lesion activity and a normal healing tissue. And so I think, as was evidenced by that one slide where I showed using strict RECIST criteria, there's only 43% response rates to vemurafenib, and then it was 100% response rates when you look at a metabolic response. I think PET is probably the best disease too to establish extent of disease when patients present with LCH. It's really the most sensitive and specific modality. With the exception of brain lesions, you really need to use MRI for those.
Yeah, you have mentioned that CNS involvement or LCH CNS improved in certain patients treated with targeted therapy. So that means, does it cross blood-brain barrier?
So that's a good question. I think most of the MAP kinase inhibitors that are on the market right now are not great blood-brain barrier blockers, but we use them for low-grade gliomas and other tumors, and I think enough gets in that it has effect. And also with the model of LCH, I think these are really, again, it requires a supply of blood cell-derived precursors to be able to cause the disease. So I think it at least blocks the differentiation of those cells.
Thank you so much. I have a couple of questions for Dr. Jeffrey and Dr. Turki. Let's start with Dr. Saeed Turki. What do you think first of all, do you know that we have national tissue banking and DNA banking? Is Dr. Turki with us? Yes, okay.
I believe there is a national biobank, I think at King Abdullah International Research Medical Center, which has a huge infrastructure accommodating millions or hundreds of thousands of samples. I think they launched the efforts to collect the samples with the phenotype and also provide multi-omics approach for those samples for researcher and physician to study various of diseases. But it's a huge effort, and it will require probably a few years to collect enough samples and make it available. But definitely there is multiple efforts in that regard. And since you used the national, I think that it was the national program as far as I know.
But do you have a system now they started to collect from all hospitals, or there is a plan to do that?
I'm not in a position to speak on their behalf, but I believe they started with 5 tertiary hospitals that's under the National Guard Hospital in different cities. And I think the policies are under the way to be accepting samples from other places. I know also in Kingswood University there is some efforts into establishing their own internal biobank in a similar fashion, but probably this will be limited to the university hospital itself. And I'm sure King Faisal and other universities are having similar approaches.
From your experience, do you think that tumor profiling, genomic profiling of cancer in our area here differ than what is in the West? We know that certain genetic diseases here due to consanguinity and other factors, but what about the tumors?
You mean the somatic testing?
Yes, for target, for example, looking for therapeutic targets in the future.
Right. So I think I can speak on the solid tumors more, since our work, my work is more focused on the solid tumors. And definitely, at least in lung cancer, for example, the frequency of mutation is different. Let's say, for example, in EGFR, in lung cancer adenocarcinoma, it's around 15% in Western populations, and in Southeast Asians, it's up to 30%, while in Saudi Arabia, it's between 20 and 25. So it's a little bit more than the European, less than the Asians. ALK fusions, for example, it used to be 7% previously. Now we are seeing up to 10% because NGS is detecting more cryptic rare forms of these fusions. So I believe with more data, I think we will see a different spectrum, not necessarily a completely new pathways, but definitely we will have our own founding mutations, different hotspot mutation. There is a nice study, if we are discussing also germline mutation from Dr. Moses Zahran in Kingswood University, where they published specific variants, only common mostly in Saudi population and the Gulf countries, not anyone else, the 106, which is now, we pick it more than the usual in the European. So definitely with more sequencing and accessibility for these services, we will see a different spectrum. But this is also true for any population, especially, the more homogeneous population, let's say.
Okay, thank you so much. I have a couple of questions for Dr. Al-Jifri. Dr. Al-Jifri, that we usually send molecular panel, bone marrow failure molecular panel, and sometimes we have negative result. So usually we are sending WES, and sometimes we have certain mutations that it's new for us, really. So what do you think really the best from the start rather than do it in 2 times? And do you think to send WES from the start, and especially for also screening the donors?
I think I understand what you mean, because we sometimes get negative results. Not to say that some of the diseases are it comes negative, but I think the best source maybe to get a fibroblast DNA to study. That will give you an accurate, because the bone marrow, maybe Dr. Turki can correct me, the bone marrow has tendency, or the blood has tendency to correct itself, but the best sample is the fibroblast to get an accurate diagnosis. WES is an important step to do it. I think nowadays in our hospital we're getting more accurate result. That used to be reported negative when we send it to another lab outside. So I think if you have high suspicion, I would go for buccal mucosa, for example, either chromosomal breakage or DNA studies for these patients.
Okay. In terms of the graft failure for Fanconi patients post stem cell transplantation, how do you condition them usually for the second transplant?
That's a very very difficult question to answer, especially if you have used, you cannot go beyond reduced intensity conditioning. I would include the TBI, small fraction of TBI, 200 centigrade, to the fludarabine and ATG, if it's not used. But I don't think you can go higher, otherwise the toxicity will be more.
I have a question here regarding the frequency of hemorrhagic cystitis in Fanconi anemia post Hablo. Especially we are using Thiotiba in Hablo.
Right. It is. I mean, the toxicity of the conditioning is expected, especially hemorrhagic cystitis. Now, hemorrhagic cystitis, you need to look also for possibility of BK or adenovirus that is known in the haplo post haplo. This is something that you need to monitor, and many of the patients, they develop this toxicity. And you cannot. I don't think if you skip the cytoxan, then you're compromising your graft. In fact, in our experience, those who had cytoxan 90 milligram with ATG have excellent survival, excellent engraftment and survival, better than the 20 milligram. So I think cytoxan is still an essential part, at least for this.
Okay, thank you so much, Dr. Jeffrey. And really, we are late today, but I would like really to conclude this session by thanking all the speaker for outstanding talk, and really we have enjoyed it. So thank you so much. Also, I would like to thank the audience for being with us till this time. Many thanks to SSBD for organizing such interesting and congress. I would like to thank the scientific committee and organizing committee for this nice organization. And with that, have a nice night, and thank you so much for being with us till this time. Thank you so much.
Thank you. Thank you, everybody.